Teams asked what language. Okay, welcome everybody. Someone might place on screen wave at me if they can hear. Okay. Excellent, thanks, Alan. Yes, it's good. Welcome everybody to our North West London Acute Provider Collaborative Board in Common for January. For visitors who have joined us, you just need to know that these meetings are recorded and the copy of them is put up on our website later. So by joining the meeting, you're agreeing to us recording your presence. And if you don't want people to see your front room, you probably want to turn your camera. Thank you very much for joining us, and thank you to colleagues in the room and colleagues who've joined us online as well. I have a welcomes I ought to do. I should welcome Mike O'Donnell, who has joined us as our first board meeting as a new non-executive for Hillingdon and Chelsea and Westminster. And also welcome Catherine Williamson, who is our new academic NED for Imperial and Chelsea Westminster. She only joined us a couple of days ago and unfortunately can't make this meeting, but she will be with us in the near future. I also want to welcome Bimmel, who has joined us as the new Chief Finance Officer at London North West. Note that this is Leslie's first meeting holding the Chief Executive's hats for both Hillingdon and Chelsea and Westminster. Probably the work that's gone on to bring those two organisations closer together, which we will talk about. I've got apologies from Nicola, one of our non-executives, and Tracy Cottrell, who is the Chief Finance Officer for Hillingdon, and I've got Gavin. Welcome, Gavin, is deputising for her. Otherwise, I think I have a full deck of cards, so that's so that is splendid. Okay, do we have any declarations of interest that anyone feels the need to share? No one owns the hospital building firm in Uxbridge. Thank you very much. And moving on to the minutes of the previous meeting, the version that is online has a correction to Simon Crawford's job title, which I think is not accurate for people who looked at this earlier, but has been updated online. Are there any other significant corrections that anybody wants to make? Punctuation to the meeting.
Just a minor correction that indicate only one of my opinions.
Okay, we will correct that then. Okay, we will, with that correction, accept those minutes, and we will move straight on then to our staff story. And Kevin, are you going to introduce it for us?
Yeah, thank you, Matthew. I'll just say a few words. I think we've got it on video, so hopefully that's lined up in the room. And I think this is an area that the People Committee in Common has really been focused on, and I know all of the four trusts are focused on it as well. And so we thought it would be good to have a staff story from somebody on the front line in A&E who has really been experiencing some of the things that can happen. You've got a short paper in the pack as well, which outlines some of the things that we've been doing at Imperial, including the meeting that Tim chairs to show the executive leadership of this. So you can read that, but all of the trusts I think are doing things, and we're linking up with each other about how we can share best practice. I think we're all seeing common benefits. And probably one thing just to highlight is trying to also not just focus on things like body-worn cameras and policies about withholding treatment, but actually about understanding patients, about the patient journey and the patient experience. And so the patient doesn't sort of become the enemy against the staff. And how could we be better understanding the patients? Because a lot of things happen because of patients' underlying medical conditions. And also, how can we de-escalate with patients. So that's probably all I'll say, Matthew, to introduce it. But you're going to hear from Giselle Lewis, who's a senior staff nurse in A&E at St Mary's.
Hi, my name is Giselle. I'm one of the senior staff nurses in adult A&E. Today I'm going to speak about some violence and aggression elements that we face in A&E. As a frontline staff working in A&E for the last 5 years, I have been part and taken the lead of various areas in the department of A&E. We see patients as they walk in the door or wheeled in an ambulance to the point they get discharged, transferred to a ward, and sometimes when they go back to their police custody. If I talk about what we face on a daily basis, if I go downstairs and speak to my nurses today, everybody will have a story of what kind of abuse they faced, be it verbal, physical, and sometimes it does cause a little bit of stress every day in life, and sometimes post-traumatic as well. When we talk about what factors lead to these patients to trigger these eventful incidents, as I'd like to say, is the expectations of care are not being met, especially the wait times in A&E. Even though clinically we are doing the best we can, we are putting new quality improvement projects and stuff like that, but still the expectations of care are not being met. Sometimes we have high intensity users, which are frequent attenders, and they have a load of factors that lead to these unpleasant events. Everyday trauma can be anything from verbally being abused, having racial comments and discrimination, and body shaming. It could be sometimes threats of a sexual nature, and worst of all, including myself, being in the receiving end of a bunch, which is not very pleasant. And including me, I think I know several other people who had to have witness statements, police recorded witness statements, and some cases still in court. So these are some of the things we experience every day when we try our best to help patients. The resilience of A&E nurses is second to none. We deal with things, we put things in perspective, and we stand tall to face the next emergency. Highlighting some of the few things we do in terms of violence and aggression we face in A&E, one of them is initiating a Code Indigo. We initiate Code Indigo, and a tannoy gets put out in the department, and it's audible to everyone in the department. And we use a code word called Code Indigo, and we know that the entire ED gets locked down, and only batch access people can get into the A&E. This happens when there is a gang-related stabbing, a trauma, a road traffic accident, when more than one individual and mostly aggression is involved. Second is the body worn cameras have been introduced by the trust, and they've really helped us. It gives patients an insight into what actually they're doing to a people who are trying to help them. The other parts, the counseling-led debrief sessions have really helped us. And the other one could be the panic alarms and the emergency alarm bells we have in every areas of the department and cubicles. And lastly, we have security presence in A&E 24/7 to safeguard, and it feels that the trust has given us some sort of health and safety measures to prevent this.
Thank you. Kevin is with us to take any questions. I'm going to open up to this. But Kevin, first of all, can you pass our thanks back to Giselle for briefing us on that? And obviously, violence against our staff is something the board takes extremely seriously, and I'd like just to talk about it a little because it is not an infrequent incident now, and it's something that some of the stories we hear are really quite disturbing. And, people are doing their best to provide a service to the public, finding themselves put under that physical or verbal abuse. It really is unacceptable, and we as a board will stand up for staff who are put in that position. Questions for Kevin about what we're doing. Simon, please.
Yeah, no, thank you, Kevin, and thank you for that. I do recall in previous times talking about people having a red card, and us being able to refuse people service. And if there are frequent people and common things, where are we at in actually implementing that red card? Because I think that would send a strong message to staff that we're actually very serious about it.
Do you want to first?
So yes, so all trusts have just reviewed their policies actually around violence and aggression, and the red carding is not particularly known as red carding anymore, and there's more new and there's understanding patients' capacity and the nuances behind that as well. But we all have very clear, in line with the policies in place now to manage that. And actually the chief nurses are just doing a piece of work to review them across the 4 trusts so we can make sure they're standardised. We've got trusts moving around each organisation now. We've got patients travelling around each organisation, particularly these more challenging patients. So we're just reviewing the policies to make sure they're streamlined across, as well as sharing some of the work around violence and aggression. So we know the success of the body-worn cameras and the confidence that gives staff. We know that the nuance of how you need to implement them with clear SOPs behind how you use them. So we're sharing that to make sure they're standardised across organisations.
Have we ever, in any of the 4 trusts, actually stopped someone?
Yeah, many times, many times, yeah.
So it's picking a line between people who are being unacceptably unpleasant, and we will stop, and people who have mental health problems who we will provide care for because we are the
Yeah, and it's understanding urgent, immediate care. You still have to provide immediate care. There are laws around that, so we do have to provide immediate care. So there are very complicated nuances that are now covered in all our policies that are in line with the national practice.
Do you want to add something to that?
Well, it was only because it was a. So we have completely revised the way that we implement these. I don't think previously we didn't have a good enough handle on how they were being implemented, and we didn't have a robust enough process. I think we do now have a much more robust process for doing this, but we do absolutely do it. The issue, I think, as Pippa alludes to, is there are some people whose behaviour is just really poor, and there are a lot of people, actually the majority, and we've now started looking every week at the incidents of violence that are reported, and it is interesting to see the proportion that are directly related to their physical as well as their mental health conditions. So the package you have to put in place has to be one of, you can red card somebody if that is the right approach, but all of the stuff that we do needs to be about the environment we're putting our patients in, the information we're giving them, the are we keeping them fed and watered and appropriately nourished. It's actually the whole thing, and that's one of the things that we've been trying to focus on with our sort of executive-led focus on this, because just slapping up posters saying we won't tolerate it just isn't good enough to do.
Thank you. Pat.
Lovely, thanks. A very good story. I just wondered within it, what's your liaison like with the Met Police? Are you getting the service that you would expect? Has there ever been consideration about posting officers in, albeit I know they would charge you for them, as sort of as neighbourhood officers and such like? Are we sort of maximising that, one for prevention, but also dealing with post?
I'm happy to take that if you want. I can't see if anybody wants to jump in the room, but yeah, I mean, we do have police liaison officer, and we also have often police in the departments, and so we particularly I think at St Mary's that we do have very good support from the police generally, and we've been doing more prosecutions, and I think that's important for staff. It's terrifying for staff, because a lot of the threat then is, you know, if you ever do anything, I will come back and get you and all that sort of stuff. So it's really terrifying, but we have had some successful prosecutions in the last month or so. So we do work very closely with the police. I don't know whether it's variable in different trusts, but broadly we've got good relationship with the police and they do what they can, I think.
Good, thank you.
If you could just add as well, Pat, so I met for a different reason with the Chief Prosecutor of London yesterday, and she's very keen to work with us around violence against staff and NHS staff protection, very much around taking it to prosecution. But what she's saying is with video-worn cameras, actually the staff member doesn't have to give evidence, you could just do it through the video recording. So she's very keen that we now start linking up with them in how we would process them quite quickly with the recorded material that we might have for some of these violent attacks.
But thanks. I know I would say this, but if you do prosecute, it does make a difference. It does tend to start driving figures down rather than ignoring it. But I know I would say that anyway, but I'm pleased to hear what's happening. Thank you.
Carolyn and then AJ.
Yeah, I think it's good to hear about the prosecutions, but I also think we should prosecute racist towards our staff. It is a crime, and I think we should definitely be really, really rigorous about that. So, and I'm not sure maybe that we have prosecuted for somebody being racist. We need to think about it. Secondly, body-worn cameras. So, and it's good to hear that they can be used prosecution purposes as well. But I don't know, does every trust have all their frontline staff have body worn cameras? No, I don't think it's completely standard, is it, across the trust? And I just think that's something that's worth considering as a more strategic issue going forward. We discussed it at our last trust standing committee, and the view was that we would really love to do it, but we don't know whether we can afford it given the current circumstances. So I do think that's a strategic issue.
I'd be interested to hear, because I was going to ask that question if you hadn't, but just from the chief executive. Tim, do you want to say something about? Because I know it's been discussed at all four trusts now.
So I'm not sure that we've reached that view. I think we have. There are issues about training about when you turn body worn cameras on and when you turn them off, and actually, of course, just wearing them is in itself a deterrent. But I do think we think it's at the moment there is obviously a cost element to any of these decisions, but it's not primarily a cost-based decision. I think there are many areas of the trust where there aren't huge problems. I think one of the interesting issues for us is, as we've started now to look every week at the number of incidents that are being reported, is that there are one or two absolute hotspots. A&E is one, major trauma ward is another, ICU intermittently is, and then there are you see pockets that come and go, and there'll be some wards that have no problems at all for months and months and months. It's one patient and their relatives, and then suddenly in the course of 2 or 3 weeks you will have a very large number of people. The other thing I should say, possibly sound like a crack record, is a lot of these patients are patients who've been in hospital for a long time, don't actually need to be in hospital.
Thank you. AJ, do you want to make a point? Then I'm going to come to John. Yes.
Thank you. Yeah, I mean, I was just going to say that we shouldn't really have a one-size-fits-all solution to this, right? We know that people with staff with disabilities and staff from the global majority are more likely, as we know in the NHS, to be attacked physically and also emotionally. And also, I think it's worth saying that I think staff who don't feel confident enough to speak up, to bring the issues up when have been abused, I think is one thing to remember. But the other thing is also about staff feeling that it's part of their job. It's like work in the NHS. It's part of the job description. It's what we need to put up with. And I think there are different streams of work within this whole area, which I think we need to.
Thanks, AJ. I'm going to take that. I'm going to let Kevin wrap us up and then move us up, if that's okay. John.
Yeah, just a final point with regards to this particular story and the emergency department. The other thing is really around prevention, and clearly when patients are in the wrong environment, e.g. corridors, or where they've been waiting for 6, 7, 8 hours, then you really hit a boiling pot, and that exacerbates. So there's something around us preventing it, make sure we keep the waiting times down, make sure we are seeing patients in an appropriate environment.
Thank you. Wrap us up.
Yeah, I just didn't want to lose Caroline's point about the racism, and that is an area that we're really working on. And you could hear from Giselle, so almost this, we can stand tall and we can cope, but it's actually working with the staff to make them, understand that this is not acceptable. We don't expect them to cope, and trying to get the reporting up and the support to them. And part of that is their colleagues, getting their colleagues to support them. Because that's been what we've heard, is that when the patient has been racist, the colleagues haven't really stood behind the individual. So I think it's part of the team response as well as the sort of prosecution response.
Thank you. Thanks, Kim. And just my last thought on the body worn cameras is that if we make a judgment about where are the high risk areas and where they need to be worn in order to provide safety for staff, then we shouldn't allow judgments around a few £1,000s here or there to be enough safe. So I think it would be good I think it'd be good if we just made sure that we could explain why we were doing different things across the different trusts, putting staff safety first. Thank you. Thanks for that, Kevin, and thank you as well for giving us the video to lead that conversation. Thank you very much. Okay, I'm moving on to item 2, which is my report as Chair, you've got my written report in the board, so I'm not going to run through that. There were just 4 things that I wanted to say. The first one was to express the thanks of the board to the staff who've worked across the Christmas and New Year period. I'm sure all the chief executives are going to say that as well. It has been a phenomenally busy period, and staff, as always, have stood up and done a hero's job. So I just like to express the thanks of the board to them. Also, to share our thanks to Patricia, who's stepped down as Chief Executive at Hillingdon Hospital at the beginning of last week, and gratitude for her hard work and effort over the past several years, including partly for COVID, and well, and for our thanks and welcome to Leslie for taking that on. I've run through the appointments that we have to our board, so I don't have to repeat those, but well, this is their first meeting. And then the last thing I just wanted to say was about the new hospitals programme, and we are in this meeting trying to balance joy with fury. In a way, so let us not let the joy of the announcement of the hospital in the first wave to be lost in this. That is something that the trust has worked really hard on, and the capital team and led by Jason has put a phenomenal amount of work into getting that from nowhere on the list into the Wave 1 programme. It's a tremendous thing for the people of Hillingdon, and gives us a clear line of sight forward. There's a big chunk of work for us to do now to make sure that we get from government support for that programme to being able to show that we can run an effective and efficient hospital that can afford to be built. But I'm confident that the team will get us there. But there's a chunk of work to be done. But that is no small achievement. So my thanks for that, and that is fantastic news for local people. What is not fantastic news for local people is St Mary's and Charing Cross being kicked out into the final wave of this programme, which means we are talking sometime in 2040 before a new hospital got built, or the election after next, which that's given what's happened over the last year in terms of political pledges to build hospitals. I think we probably aren't hanging our hat on that as a commitment either at the moment. But that clearly can't be allowed to stand, and what we now need is for the Treasury to engage with us properly in, okay, we have the finances of the NHS and of the Treasury, but what are we going to do together in order to find a creative way to take this forward? I'm going to hand this over to Tim to say some more about this, because this is something you've been working on for the whole of your tenure as chief executive. So I wouldn't be forget you.
Thanks, Matthew. Yes, and the reason for taking a bit of time on this is because I do think, given the announcement yesterday, the non-executive directors for Imperial, but actually all of the non-executive directors of this board in common, need to understand where we think we sit in terms of risk for the ability to provide care. So to be clear, yesterday the government announced the outcome of the review. St Mary's, Charing Cross and Hammersmith all fall into wave 3, which means that they start to build somewhere between 2035 and 2039. On the face of it, that means that we will have to stop all activity related to redevelopment until 2030. That means, of course, the end of the redevelopment programme that has been going on for many years, the loss potentially of millions of pounds worth of work and indeed central investment. It's probably worth just a little bit of the history. I started at St Mary's as a consultant in the year 2001, and I went to meetings about the development of the Paddington Health Campus when I was a relatively new consultant. So we have known about, and it has been accepted, there is a need to redevelop St Mary's for 25 years. everybody who visits knows that St Mary's needs to be rebuilt and are quite often shocked by the state of the estate, some of which is now 180 years old. By the time this build is finished, potentially, we would be providing care in buildings that were 200 years old. The problem is that successive governments have kicked the can down the road in the last 25 years and have left us with the task of running a group of major hospitals that have simply not been maintained. The one thing that we are incredibly fortunate to have is a group of extraordinary clinicians, and we have a wider workforce who have really been prepared to go the extra mile to compensate for the estate. Our estate teams, to be honest, have been little less than miracle workers. But the ask to continue in that way until the 2040s is just too much. It is simply impossible to envisage that that's the right thing to do. All three of our main sites, and as well, of course, as the Western Eye, which is due to be incorporated into one of the developments, have had major issues in the very recent past. In the last few months at St Mary's, we have had to close theatres for several weeks in order to repair leaks in the roof. We've had floods. We have a ward closed because the floor will not bear the weight of hospital beds. We have had to remove some specialist services from a building to repair subsidence that could have meant the corner of the building collapsing into Paddington Station. And we simply don't have enough capacity. At Charing Cross, we've lost the power and lights to theatres, including our robotic theatres. Whole wings have been left without water on occasion and indeed heating. Similarly, flooding, limits of power and light at Hammersmith, and the Western Eye actually had to be closed for 18 months for remedial fire safety works. So it is important, I think, that everybody understands that these are not problems for the future. These are the problems for now. Every time we fix a problem, there is another one that pops out. And the scale and the impact of those is increasing. But actually, of course, these hospitals provide care for 1.4 million patients a year. They provide most of the specialist care for the whole of the 2.5 million people who live in northwest London. We have the busiest of the capital's major trauma centres, as well as specialist stroke and heart attack centres for the sector. And of course, with our academic partner, we're running over 1,000 clinical trials each year, contributing to breakthroughs with both national and global impact. But from our perspective, this is like an increasingly frantic game of whack-a-mole. And that sort of approach to estates maintenance will, at some stage, just stop. We will not be able to whack the mole. And at that point, it is quite possible that one of our sites will go down. It's also possible now, with the delay for all three sites, that more than one of our sites could go down at the same time. At which point, you have then basically trashed the ability to provide specialist care in northwest London. And that has an impact in northwest London, but it also has an impact across the whole of the capital. Having articulated the problem, I think probably I should focus on. You will, I think, have seen the statement we issued yesterday. I think devastating is the right word for the impact on the communities, the staff, and our patients. But of course, the primary job we have is to look after all of the patients who come to us for care. And that will continue to be the single thing that drives us. Of course, we cannot just sit here and wait for 15 years in order to get some hospitals built when they are already crumbling. I think it will be very important to look at the detail of yesterday's announcement and what it means for the schemes. But we do know we have no option but to progress redevelopment more quickly. We just cannot sit here. And so I think there are some significant opportunities. St Mary's in particular has unique features which I think allow us to potentially exercise those. the current hospital, which has been developed piecemeal across the sprawling site in central London, we do now have a practical plan for. It's got widespread support. We have consulted widely on it, and we will build a hospital on a much smaller footprint, freeing up significant land for other uses. Our existing partnerships, Imperial College, Westminster City Council, the 15 co-located life science tech and data companies under the banner of Paddington Life Sciences, could contribute 1.5 billion pounds a year to the UK economy if we are able to redevelop the site to allow its further expansion. And the decades of attempted redevelopments have had one small advantage, which is we have explored every conceivable option for redevelopment, including looking at alternative sites. And we have done that multiple times. To be clear, we do not need to do that again. We have done it over and over again. We have done an unbelievable amount of analysis of the situation. We know that the current scheme is the best option, and we know it is viable. So we need to explore all possible means of funding the redevelopments, including working with our Paddington Life Science and other partners. We also, of course, need to work with the government. We will also need to work with our local councils and MPs, and we know that they share our deep sense of disappointment. We try and pursue the wider case. And the key first step is to find a way to complete detailed design and achieve a planning consent for St Mary's Hospital and the wider campus. That needs a relatively small amount of investment. And I am hopeful that if we can have some sensible conversations with government, we can hopefully work out a way of releasing that money to get to that point. That, of course, changes the whole outlook for that scheme. Because we know that the scale and needs of St Mary's mean that it does come with a price tag to match. And it is clear, looking at the list of new hospital programme schemes, that it has struggled most with the biggest schemes, all of which, as far as I can see, are currently in the last phase of the programme. But of course, this is a scheme on the Mary's campus, which actually has the opportunity to contribute to this growth agenda for the UK. And we absolutely have the responsibility to address the very clear needs and indeed the opportunities I think I've just been through. If we don't, the consequences are too big to just keep kicking the redevelopment cans down the road. I apologise for a rather lengthy summary. Last thing I want to do before I finish is to, I'm not, didn't come to the board, I think. I wanted to acknowledge the huge efforts and skill of our redevelopment team. So they have worked unbelievably hard over the last few years to establish great plans for all of our campuses. They are, of course, devastated today, as I know much of the rest of the workforce will be, and indeed our partners.
Thank you, Tim. Very modulated response compared to the response I had on the phone last night. So, well done. It is clear, and I'm sure the support board is right with Tim's words. I'm not going to open it up for debate because I think we'll end up with spending the next hour debating how disappointed we are. Probably isn't moving forward. But the point I think I hope you will heard from both Sid and I is that we don't consider this to be the end of this story. We continue to be interested in pointing into the chapter, and we now need to have the conversation about the health needs of the people of North West London, which are not being met here, but also the economic needs of the UK economy, which, if we are going to have a vibrant life sciences industry, without Imperial College Hospital. So we need to step up together, find a route with the government through this in order to be able to start to make progress. Thank you, Tim. Okay, I'm going to move us on. Matthew, no doubt we'll be coming back.
I just want to say something about Hillingdon, because I understand the situation with Imperial, but I've been around this table, I think, longer than any other person around this table involved in it. When I was involved in Hillingdon, we were nowhere. And to have come nowhere to where we're at and is a major, major achievement. And I think, you know, you acknowledge Jason and the team, but, you know, the work that they did to get us with others to be in that #1 list is a major achievement. I think for the minutes, we should note our appreciation of Jason and the team.
Absolutely. Yeah, I hope that. I think so. And now lots of work to be done, but that is great news. And if it hadn't been for that work, we'd be sitting here being angry and upset about both projects. So yes, it's trying to get both points.
Yeah, I know you want to move on, so I'll be very quick. I mean, I find this decision really confounding, given the amount of money we're spending on day-to-day repairs. I don't know whether the government understands that if you were to capitalize that amount of money they were spending on repairs, you would get a new hospital. Now, putting that aside, I think Tim is entirely right when he talks about going for planning permission now. It takes 3 years to get planning anyway, given the scale that we've got at St. Mary's. We've got to start that work now, and we've got to find money. And if you have planning in the bag, then that is a tool that we can use to convince government to bring the program forward in the future.
Thank you. Yes.
I mean, there is no rhyme or reason. It doesn't feel like there's any rhyme or reason, but there are reasons. And I think what we need to consider, and maybe not for anything, we just need to think, how do we up the ante on this one, and what are the routes in to the various decision makers that we need to use, you know, local authorities, MPs, direct treasury, just to try and get a deal, not in terms of them giving us money, but finding a way through that will enable us to progress it, because there'll be lots of reasons as to why this was not in the first wave or the second wave, but we need to try and think through how do we campaign for it, not, I don't mean in the press, but scenes, but also how do we present some options that allow the government.
Wrap this up for us. So just described your last 3 years.
Yes, exactly. So I think we have. I mean, I'm afraid I do think we know the reasons for the decision. I think we have worked very closely. The redevelopment team worked incredibly closely with the new hospitals team. I am not sure how much input in the end the new hospitals team had into the decisions. We have had very senior contacts throughout the whole process, but you're right. The job now is to redouble our efforts to say there is a relatively small amount of investment that can take this project to the next stage, and I think we have to probably really redouble our efforts with regard to parts of government that are not health. It's DCIT, it's business, and it's the Treasury, because this is a scheme that will have a net financial benefit for the country. And the problem is, I think there is a view that the NHS is basically a sump for money, and people find it very difficult to believe that you could have something that could actually be a financial benefit. And that is the bit we've got to convince them. And that, I think, is where Paddington Life Sciences really comes into this.
Thank you. Thank you for that. Thank you for everyone's contributions. I'm going to move us on, and I'm going to move us on to the paper 2.2, which is the note of the implementation of the shared leadership model. I have paper. Did you want to say something about this? This is your paper. Introduce yourself and then.
Peter Jenkinson, Director of Corporate Governance. No, I wasn't planning to say much about it actually, apart from I think the paper hopefully describes where we got to from October and the decisions from the standing committees and the board in common around the process that we're going to follow, and with support from HR colleagues and others, I think we have executed that plan. And as you said earlier, we have an outcome from that which you announced in.
Thank you. So this is for the board to note. We've discussed this on several times as we've been going through the process. So this is to note that we have brought it to conclusion. So I hope everybody's happy to know. Thank you. And then I will move on to the summary notes from the board in common cabinet, which you'll remember that the cabinet exists to deal with matters that arise between board meetings that can't wait for the board meeting. So the see in the notes that we discussed some regulatory issues. We discussed the elective orthopaedic centre, and we discussed finances review, which we will be coming back to later. So I'll just draw that to the board's attention to note. And then I'm going to move us on to section 3, and which is for approval, and it's the evolving collective governance programs. And Peter, back to you.
Thanks, Matthew. So just a few words of introduction around the decision we're taking today. I'll take the rest of the paper as read. Take questions, but I'll remind the board in common that back in October, last meeting, we approved a revised scheme of delegation for the collaborative and terms of a generic set of terms of reference for the standing committees. Given the decision to establish those. The purpose of bringing it back again today is there are some minor revisions to the scheme of delegation and the terms of reference to reflect largely about the evolving practice that we have around the standing committees. So the terms of reference for the 4 standing committees have been through the standing committees and have been agreed. So this is a generic set. There are minor amendments at each trust level to reflect local arrangements. But having had them approved at the standing committee, we are seeking approval of that generic set of terms of reference here. Similarly, with the scheme of delegation, this is to reflect some minor amendments to that scheme of delegation, again, largely to reflect the practice that we've implementing through the maturity and increasing maturity of the standing committees. And then lastly, the third part of this paper is the MOU, the Memorandum of Understanding for the collaborative. You'll remember that we established, when we first established the collaborative, we had a statement of intent, which was a fairly brief, kind of a very high level document. What we've done is codified again a lot of the practice that we've evolved over the last 2 or 3 years into a memorandum of understanding, which reflects the practice that we follow. And that was approved by the board in common cabinet. It's been brought here today for agreement by the full board.
Thank you. Thanks for that, Peter. Any questions? Okay, can I ask?
I have one.
Nick, and can I ask you to introduce yourself?
Sorry, yeah, Nick Ash, non-executive director, Imperial England, sort of asking this question as an audit chair and governance nerd. I just had a question in terms of the technicalities of approval of that, because this refers to the trust boards in singular. And I take it that technically what we are doing is each individual trust board, meeting separately, is agreeing that this is its delegation. So technically there are 4 decisions being made here, each by the separate boards. Now we can all say yes together, but that's technically what we're doing, isn't it?
That's right. Yeah. The board in common is made up of 4 trust boards.
Yes, meeting simultaneously.
Yes, that are meeting simultaneously all in the same place, because it just struck me that if we're doing collectively, you could sort of pluralise the trusts. But technically, we are doing it individually.
When I ask for agreement, I'm asking for people to agree board on which they sit.
Yes, all the board. Yeah.
Any other questions? Okay, so on that basis, can I ask whether the board members are happy for their organisations? If anyone shakes their head, I'm going to have to then pick apart the 4 organisations. Is everybody happy with it? Thank you very much indeed. Yes, and thanks for that clarification. So moving on to the integrated quality and workforce report, I think that I am probably turning to Pippa first. Pippa, for people who don't know you, which is almost nobody.
Hi, I'm Pippa Nightingale, Chief Exec at London North West, and I lead the quality work stream across the APC. So just to cover off the quality and highlights, I won't go into the detail. It's been done in detail at each quality committee and at the APC quality committee, but largely it's a really positive story actually for quality, with some shows us a good culture of reporting with low risk and low levels of serious harm. It shows us a very good patient experience outcomes in most of the settings, particularly in the ED setting, which I think is really important, and credit to our staff. Actually, we're going to talk quite a lot about the pressures of our urgent and emergency care departments, but actually the overall experience of staff is high, patients is higher than the national average. Great compliance with BT risk assessment, since we've now all 4 trusts on Cerner as our recording record. That has really improved our compliance with BT risk assessment, and a fantastic mortality score with 3 trusts lower than the national average, or lower than expected, and 1 as expected for mortality. So some of the safest quality metrics that we can see. Maternity as well isn't showing any outliers really. Our crude stillbirth rate goes up in month, but year to date is a score of 3 against a target of 3.3. So nothing really standing out there in maternity scores neither. The biggest conversation we had is around infection control scores. That's in line with a national picture. We've got lots of work, lots of detailed work around understanding some of our reasons behind that, and the work that we're doing to encourage and remind staff to use appropriate PPE equipment in the right settings and to guard it in the right moments as well. But otherwise, really nothing to highlight, I don't think.
Thank you very much. Any questions on the quality section of? Okay, thank you very much, and we will come back to quality again shortly. Let me come back to you to talk about workforce.
We were going to run all 3 quality and then do workforce.
Okay, right. Yeah. Very good.
Over to Janice to do.
Yes, I'll turn to Janice to talk us through the.
Thank you.
Thank you, Janice.
Yeah. Thank you. Thank you very much. Be brief, really. Obviously, the safeguarding agenda is a very important aspect of care, treatment and management of our patients and their families, and our staff increasingly. What you've got here is a summation of the 4 annual reports from the members of the trust members of the APC. They've been summarised for the purpose of giving assurance to this board in common that we've got everything we need to have in place to deliver a safe safeguarding service. I think what I would do if people have questions is refer those to the quality committees of the individual organisations. Each quality committee will have seen their annual report, and their annual safeguarding report is also posted on the internet sites of each trust within the collaborative. I mean, there are aspects of education, training, leadership, and participation in borough-based working around safeguarding that are captured in this report and the individual annual reports. And there's nothing of any concern that I feel I need to escalate or raise here to this board in common. Thanks, Matthew.
Thanks. And Janice is our Director of Nursing. Carolyn, did you have a question?
I had a comment really as much as a question, if that's all right. So thank you very much, Janice, and it was very good to see the reassurance from all 4 different trusts. So as Janice says, I did actually read all 4 reports because it's an area I am really interested in. So I think it's really good that we've got that level of assurance. However, each of the reports is completely different and covers different issues. I have to say I particularly enjoyed reading your report, Pippa, which had case studies in it, which I think really brings it to life in terms of what actually some of the issues are. But what I really thought, you know, for us as a collaborative, is we really should be thinking about, should we be standardising these reports and covering the same issues, number one? Maybe, you know, and there's always going to be some variation, no issue with that. But secondly, what are the issues in common across the 4 trusts that we maybe need to be looking at and helping each other? Then I thought, on top of that, do we all need to be doing the same thing 4 times as well? Could we organise ourselves differently? Anyway, it raised for me lots of different questions, not about each individual trust, because I was totally reassured on that, but about could we do this differently and better as a collaborative? That's all.
Thank you.
Janice, do you want to go on that, or do you want me to answer?
Perhaps I'll make a start and then you could round up. I mean, I've read all 4 as well, like you, and they are all slightly different, although I think they do all cover the same issues in a different way. We've talked about whether we would bring the safeguarding teams together and put in a standardized approach. And I think I just want to make sure that adds value really, and that it's a good use of energy and effort for those teams. But it's certainly it is certainly something we could look at, whether we'll manage it for the next annual report, because we're almost at the end of the year. And this refers to the previous year, but I can certainly start that ball rolling, I think, Carolyn. And I think your point about what can we learn from each other, I think, is well made. Those 4 teams already meet and talk through sharing of good practice and issues and difficulties that they have. I think there's probably something around training we could all do together. We're already using some of the NHSE platform training. We're already accessing the National Oliver McGowan training, but there may be other bits and pieces that might be helpful, as well as some aspects of supervision, I think, for the staff involved in safeguarding at the level 3 and level 4 end. So we can certainly have a look at that and get those teams together to see where they think they can add some value by pooling resources and intelligence and things that work and don't work.
Completely agree. So I think they will naturally start to be more aligned. I don't think we should be purists on that. Statutory organisations, safeguarding is a statutory requirement, and it has to be local to your population. So the reason there's some differences slightly in the presentation of London North West is the work in that community needs to be different, and we've done a lot of work around honour-based violence and some of the cultural work in them communities. So we have to allow it to be localised to community needs as well. But I think, as Janice says, bringing our safeguarding leads together to learn at what works well, what can do together would be helpful, and we'll do that in the future.
Thank you. Yes, I would say, I'm sure most people around the table have read all of them. But more like I had much to say. But so I do think that standardising the presentation more will help us spot where there are read across lessons. And they're against the framework, which is what is required in reports. It shouldn't be that hard to standardise. That doesn't stop individual organisations digging deeper on the areas that are important to them. Whether bringing the safeguarding teams together or not is the right thing to do, I think, is a chief executive, director of nursing decision. The reason that we run our board like we do with 4 separate boards is so we don't lose the granularity of caring about what's going on in the individual hospitals. And whilst there may be advantages of bringing it together, and I would be against it if that was a recommendation, equally I wouldn't want to run the risk of creating a super team that wasn't down in the nitty-gritty detail of what was going on across our 12 separate sites. So I think making sure we get that balance of really close local scrutiny as well as making it easier for the board to read them, there's a balance to be captured there.
So if I could just come back on that, because I thought the suggestion about some of the training and doing that more collaboratively was really sensible. So I think if we could progress that, that would be great.
Great, thank you. Thank you for that. Thank you, Janice.
Thank you.
So moving on to John, introduce yourself and then the Learning from Deaths report.
Hi, I'm John. I'm the Chief Medical Officer at London North West Hospitals, and I lead on mortality for the medical directors across the collaborative. So as usual, the report looks at the 2 measures that we use, HSMR and SHIMI, slightly different each one. All our organisations are either lower or as expected for mortality, which was the same as previously. We continue to scrutinise around that all mortality areas which may show any spikes, and by that I mean we review in detail a clinical case notes review of those, and those get brought to a meeting which I chair quarterly, where we review anything unexpected, and we haven't found any care issues through those as of this date. The only other thing to note probably for this time is that there is a change in methodology even coming for HSMR, which may show an increase in HSMR specifically, although not necessarily a relative increase as in rankings, and that will kick in over the coming months, and we will report back on that at the next reporting period. Thank you, Chair.
Thank you. Any questions? Yes, please, Sim. introduce yourself.
Thank you. Sin Skabazza, a NED at Imperial and London North West. And I'm really pleased, John, with this report, and we continue to track this through the quality committees of each site. But I think what's really interesting is there's perhaps a fear with the public that some of the corridor care or the sort of the demand that we've got, the high demand, is causing an increase in death spike, and it's really reassuring to see here that that's not the case for us. So I think it's probably just wanted to say that we're pleased that the care that we offer in all of our sites is safe, and despite the demand and despite the harrowing scenes that sometimes we see, we are still providing safe. Thanks,
So I
John.
just coming back quickly on that. So all our mortality is excellent. I think we should just all note that the two sites with the highest mortality are the two sites where we've had the most corridor care, which is Hillingdon and Northwick Park. But the mortality there is still very, very low compared to other organisations. But it's very difficult to dig into. We haven't found any particular association, but it's just something to note.
Thanks, John. Anita,
Anita Manchandra, I'm a NED at Hillingdon, at Chelsea. Just to follow on from Sim's question and comment, it's very good to see that the mortality indicators remain low despite the high demands. But I wondered if there are any other indicators that are throwing up these pressures. Is it coming in serious incidents or other factors that are not actually mortality, but we're seeing some impact on the quality of care? How are we tracking that?
So London North West, for example, has had a spike in incidents, but not harm. So what's reassuring about that is clearly things are more challenged in areas, and that's around the Northwick Park site over the winter. We show more episodes that are reported, but actually when we dig into them, we haven't had any specific episodes of harm, which is reassuring. And so we do triangulate it in that method as well across the sites. And of course, as well as the mortality data that we're reporting here, there's what we call level 2 reviews, which are reported on in the report, and they look at then suboptimal care in greater detail as a further triangulation. And you can see the levels in there, which continue to be low.
Thank you. Leslie, did you want to come in? And then...
Just a couple of things. So I think mortality and the sort of growth indicators are very good. So, but actually, we shouldn't be complacent about the fact that we are looking after patients in settings that we shouldn't be looking after. The patients are being moved around hospital in a way we wouldn't want them to. And so we do need to continue the work that says, and actually people are coming in and dying in our hospital. They might be expected, but we would have preferred them to die in a more therapeutic setting. So, so I think there's still quite a lot of work to do around all of this.
And I think the two indicators that would probably tell us more are the experience indicators. So, you know, the patient experience, but also the staff experience. How are staff feeling caring for patients in settings that they not ideally want to be caring for them in? They are absolutely doing their best to keep patients safe. And we see that in our mortality data, we're seeing it in our incident data, but the patient experience data is what we'll keep.
Thank you. Saeed, can you introduce yourself?
Thank you, Saeed Mohinuddin, NED at London North West and Chelsea and Westminster. John, thank you. I was just curious about the Appendix 2, the ethnicity. Now, while it's good that we are able to break it down by ethnicity, but this is the numerator data. We don't have the denominator data. And I just wonder whether some ethnic groups are much more have a higher level of mortality, because you can't interpret that looking at this particular bit. Thank you. Any help in that direction?
When we last looked, it was actually white Caucasian males that had a higher increased mortality. When we looked, when we last managed to dig in, do a deep dive into that, the data's improved, but it's I have to say, we have really struggled to get anything meaningful in terms of then addressing those root causes.
Thank you. And it's worth saying that one of the key projects for digital teams has been to ensure that we have ethnicity and other indicator data on the core data set in order that we can do better quality, precisely analysis that Saeed's talking about. Thank you. Okay, with that, I'm going to move us on and invite Pat do you want to just summarise from the Quality Committee, Collaborative Quality Committee, and introduce yourself, please?
Hi, Pat Gallen, Vice Chair at Chelsea and Westminster, and Chair of the Quality Committee. I mean, it's very much as Pippa said. The only sort of additional highlight that I would pick out that we did discuss in more detail than necessarily comes up in the minutes is about the issue about Martha's Law, where everybody is bringing in the pilot sites. I think it will take a little bit of time to ensure that we've got it absolutely right and everybody's getting the second advice where they require it and ask for it, because the issue is around paediatrics, as I recall from the meeting. Everything else is as read on the paper.
Just for the benefits of people joining, just describe what Martha's Law is.
Yes, so Martha's Law is a law that came in after a family campaigned when their child died of sepsis, and they felt that their concerns were not heard within a hospital in North West London. So it is now a parent's ability to contact a number that they will get support and be heard, and a review of their concerns be made in terms of their child or adult. We were pilot sites, all 4 of our trusts were pilot sites. We've got it in place for adults, we've got it in place for children in all 3 sites apart from London North West, and it goes live in paediatrics in February in London North West. So we will actually be one of the first systems to have Martha's Law in place in all of our sites for both adults and children. And actually just reviewing the data, we'd had 74 contacts to the centres across all the phone numbers across all 4 sites where we have been able to intervene. Now, some of that was inappropriate use of it, and it was more like a PAL service, and we're going to have to work through that and the nuances and all of that. But actually, in some instances, we have been able to intervene and either usually support families with more information, actually, and second opinions. So it's evolving quite fast in all of our organisations, and clinicians have really embraced it, actually, and made sure it's implemented smoothly.
Thank you. Martin, introduce yourself.
Hi, Martin Lupton. I am a NED at the Hillingdon and London North West. Pippa, I'm interested in the sites where it was introduced. What efforts did we make to support those populations of parents who would not normally challenge the system? So I might ask for a second opinion. I would feel it was my right, but there are others who might never even think of it. How did we make sure they chose to?
So, I mean, we've all got campaigns that we've put out there. So we've put posters, we've put in material out there on our website, we've put information out there for all of our patients and relatives to use. And actually, when we look at the people that are accessing them, they are very much from diverse groups. Certainly, I can take the numbers from London North West, we're very much from diverse groups and different populations. They are not the normal voices that you would hear, because they would probably voice their concerns directly to a clinician. So it does seem to be an easier route where you've got a phone number where you can contact, rather than having what might be a conflicting conversation or a challenging conversation with a clinician providing that direct care.
Thank you.
Raymond.
Thank you. I'm Raymond McWayne, Medical Director at Imperial. I'm the work stream lead for the deteriorating patient for the APC, and we've been taking the Martha's Law work forward. So to answer your question further, we've done quite a lot of work in the planning across all 4 organisations, and we've really been able to involve our patient representatives, and they've come from a really diverse group. And so we've gone through different phases of the project, and we're now at the stage where some of our patient information is being translated into different languages, for example. So their feedback and input has been really, really helpful. So right from the start, we've been able to incorporate a very diverse patient group, as Pippa says. It is evolving, it is developing. And the numbers show that actually we have managed to reach and support a diverse group of patients across all 4 organisations. Just very recently, we were able to bring together all 4 organisations to a face-to-face shared learning event. And some of the learning, particularly from London North West, actually, was that having ward-based champions and people who are very visible and involved in the daily care and able to represent those the needs and the wants of patients who may not necessarily step forward has been very helpful for that group. So we've had that sort of cross-fertilization of learning across all 4 organisations. But it is new for all of us, but it does feel like we're hitting the right space with this work. And I will be quiet in a moment. Probably the other thing to say is, and we've learned as we've gone along, it's been really important to be clear about what the project is. as well as what it isn't. So it absolutely is a safety net. It is an alternative route for patients, their families, for carers to be heard and to express concerns. But it's a top up to our normal care and our normal processes, which are actually really excellent. So we'd be worried if people were using that as the default route of care. We've got really good processes and systems in place for that. This is an extra safety net, and it seems to be adding value, but we'll continue to try and improve it.
Thank you. Sorry, Sid, yes, please.
A question for you, Matthew, actually. The mental health in acute trusts. We know that we are spending money on mental health nurses, which is outside of the establishment, and that's costing us money, and obviously it's affecting our numbers. And we know we have to do this because the presentation with mental health cases is extreme and worse. What I'm interested in, you had a meeting with Tom and Penny from the ICB. Is there a system response? Do they have a view on mutual aid across the system to be able to help us with this continued issue? Matthew.
I'm going to bounce that question to the chief executive. Leslie, go.
Two things. So we're in the middle of discussion, obviously, with health organisations, but actually a number of patients aren't just from the North West London Mental Health Trust, but further afield. There has been a London discussion, and actually there's a national discussion as we start to look at planning for next year, which says if we. I mean, there's a bigger issue about the care of those patients actually, but you know where the costs for that should sit and how we well, there's more than that actually. There's a piece of work that says what's the demand and capacity for those patients by borough and by trust that says, and by ICB that says, have we got the demand and capacity right? And then there's the whole issue about how you fund all of that. So those discussions are actually going on.
Thank you. Okay, thank you very much, and thank you. And I'm going to move, I think, back to you, Pippa, to introduce the workforce.
Okay, so you'll see on the IQPR, workforce looks very positive actually. For the first time, we are compliant in all of our standards. So we've got a vacancy rate lower than the national average in our own target. We've got a turnover rate that is lower. We've got an agency spend that is lower than 2%, and in 3 organisations sitting at 1%. And we've complied with our core skills and appraisal. So all looking in the right direction. That leaves us 2 areas of focus, which I'm sure David will pick up when we talk about what we discussed in the committee. But it is very much now around workforce planning, making sure we have the right size workforce that we can afford. That is particularly important next year as we go into what we know will be a challenging financial year. And the second piece of work that we really are focusing on is our workforce res equality data, and ensuring that we have a workforce that is representative of our band 5 workforce and our more senior bandings, and we've got lots of work around that. So there are 2 big areas of focus, but actually very positive workforce metrics.
Thank you. Any questions? Yes, can I David for the report from the
Thank you, Matthew. So I'm David Moss, the Vice Chair of London North West, and also chair the People Committee, and I am a NED at Imperial. Pip has said the vast majority of things that we actually covered at the APC People Committee. There are just a couple of things I'd like to add. One is we shouldn't underestimate the impact of having more people than we can afford. Now, that doesn't mean to say that we should be issuing instructions to cut the workforce. That's not what this is about. This is about how we smarter with the workforce we have. Are they performing at optimum, and are they working in the right areas? There's a bit of work to be done around that. Secondly, there are 2 or 3 programs in what's called the People Program that are really good. Well, there's quite a few things that are really good, but these particular 3 need accelerating. So we're after some change, but with some pace, and that would cover them as well. The third thing, and I would argue is the most important thing, is in fact the point that Giselle covered earlier today around violence and aggression against staff. All 4 people committees, and certainly the APC people committee, see this as the biggest thing on the agenda. Because if we can't look after our staff and the health and safety of our staff, then we really have a problem. So that is paramount, and I was very grateful for Giselle and Kevin for raising that to the top of the agenda today. So those are the three things I would just have added, Matthew. Thank you very much.
Thank you, David. Any questions or comments? Baljet first, yes. You introduce yourself, please.
Baljet, Ned at London North West and Hillingdon. Just on the productivity piece that is referenced in the report, just wondered if you say a bit more about focus on productivity, given our gloomy financial forecast for the future.
Yeah, I think it's, I mean, I'll give it a go and then see anybody else is welcome to. I think it's fair to say, Baljet, that the way we focus on productivity is not perhaps the same way organisations outside the NHS focus on productivity. And therefore, I think there's some cross-learning we can do, certainly at the committee, to help influence that direction. I have a particular concern that we talk about the number of people in our organisation, but we don't really look at the performance of our individual people within our organisation, other than an annual appraisal. And I think, therefore, there's more we can do around focusing on people's performance and therefore their productivity. So Baljet, to put it politely, I think it's work in progress.
Yeah, so can I just say that, and I will use today as an example. So in the deep dive today, when we look at productivity by consultant, by list, we absolutely do. So we could definitely do more, David. You're absolutely right. But do we look at productivity by individuals and by service? Yeah, we do. And we should just say we're doing a piece of work across the 4 trusts at the moment with some external help, really looking at medical productivity. So looking at GERF metrics. So GERF metrics are very clear. How many patients should be seen in the clinic, appointments, how many operations should be performed. So we're looking at job planning and medical productivity. It probably will drive some work that we can then deliver next year. So it's helpful that we're doing it at this point. So we've got, as Leslie says, the basics. Delve into that a little bit more. And when we talk about workforce reduction, we need to be clear, we're not talking about redundancies, we're not talking about anything in substantive posts, we're talking about a reduction in our bank and agency spend and WLIs. So our WLIs are very expensive. It's a weighted initiative where consultants are being paid additional to the extra work.
No.
Fine, we just, because there is an overall question about numbers of staff in post and productivity. And so what we're doing is a bridge between those that we were asked to put in for certain things like the maternity investment or actually for mental health and things, and then those that we're going to need to explain or take out. So that is an absolute challenge that we're looking at, David.
Well, I think the question isn't necessarily what are people doing, it's that we don't have a good way of reporting where we are on productivity to the board. So some of that stuff will be visible to Ned, and I do think we need, given that the financial constraints we're operating under, productivity is going to be a big part of the game next year. We need to be able to bring to the board an understanding of what is our productivity, where are we doing really well, where are we doing less well, where we know in the grand figures that we are, broadly speaking, more productive than most other hospitals across the country, but that's not the same as being as productive as we could be. And I think we all know that productivity isn't about staff not working hard enough. It's about us not supporting staff to work well enough, and therefore, so this isn't about people not using their time, not working really hard. It's about how we run, how do we run, and are there things we can do? And we do need to get a set of metrics, not just about workforce productivity, but generally about our productivity that allows us to know how we're doing. Tim.
Just to pick up, I just wanted to pick up with what I think it's in some respects unfortunate that the productivity discussion has come at the workforce section of this meeting, but I do think we need to be really clear. This is about system productivity. This is not about individuals, how hard they're working. It is our job to create a system that allows people to start their theatre with the right equipment, having had all the patients pre-assessed appropriately. These are system issues, and I think we absolutely, and we are absolutely looking, and I'm sure Jazz will speak later, how we can define really clearly where we are and where we want to move to in terms of productivity. And as you will have, I think, experienced at the APC F&P, it is tricky, but we are actually working through quite really carefully to get that by specialty, by trust, so that we can do that level of deep dive because we're going to need to.
Thank you.
Just on that, sorry, just on that, that would be, oh no, carry on.
Sorry, my question's actually largely been answered by you talked about the external help that we're getting on productivity, what that is, and the question was when's that going to be completed? When will we see that? And other productivity initiatives, where are we going to see them? Just to manage everyone's expectations, because it's top of mind given our financial pressures. And we have an overview of where is all of this being reported. And
We honestly do it when Jazz does her.
You pick that up for us, really, Jazz. Excellent. We'll park that for you.
Well, and maybe I should park it as well. I mean, so I just think for those of us who are not steeped in NHS way of presenting information, when we do have a conversation about productivity at board level, rather than, you know, as within executives who all were steeped in all of that stuff, I think it's got to be understandable, and it's got to relate to what we all understand as productivity. I'm not sure that currently when we have those conversations we're talking about the same things, because anyway, maybe you're going to cover that, Jazz, I don't know.
But let's come back to that in the finance finance conversation. Okay, thank you very much. In which case I shall move us swiftly on to Leslie and finance and performance overview.
Thank you. So we'll start with performance because, and then we'll come on to, we'll keep you all hanging then for the finance and the productivity conversation. So look, it's been challenging, and you'll have seen that through all of the chief exec's report, and internationally, you know, the emergency workload has been challenging, but people have worked incredibly hard and done, in relative terms, a very good job. So but let's do a little bit of detail. So we'll nip round. That's right. We'll start with Claire and urgent emergency care.
Thank you, Leslie. Afternoon, everybody. I'm Claire Hook. I'm the Chief Operating Officer and Deputy Chief Exec at Imperial. So I'll quickly run through where we are with our urgent and emergency care performance. Our ambulance handover times are reasonably steady. We recognise there's still more that we need to do to A, stay on top of those, and B, improve them. But it's worth noting that of our 7 emergency departments in North West London, we consistently occupy the top 8 spots in terms of in terms of handover times in London. So we benchmark well. The outlier within that is Northwick Park Hospital, and we've talked here before about some of the challenges they have, the work that they're doing, and the volume of ambulances that they receive. So that's a work in progress to make sure that we continue to improve our handover performance there. From a waiting times in the emergency department perspective, our performance has dropped off over the winter, so more patients have waited for more than 4 hours. We expected that to happen because of the winter pressures, but the drop off in performance has actually been worse than what we thought it would be. Now, there is a huge amount in there that we can do to work on our own processes, and we are absolutely doing that. But the driver really of that unexpected change has been about the level of infectious disease within our community, presentations to ED, and some of the challenges that presents us with then managing flow on through our hospitals. The 2 EDs that are the most challenged at the moment in terms of their 4-hour performance, as we talked about before, are the Hillingdon and Northwick Park. And there's some detail in there about the specific work that's happening in the Chief Executive's report. So I won't cover that again unless anybody's got questions. But in general terms, we all have improvement plans in place. We're all meeting to the majority of cases, the NHS England guidance about urgent and emergency care, and we're all working together to manage the pressures as best we can across our systems to make sure that our patients are seen as quickly as possible. In terms of our very long waits in the emergency departments, they've actually improved slightly, but they are still nowhere near where we would want them to be. So that continues to be a work in progress. And that actually relates much more to our processes for managing flow through our hospitals and then discharge out of our hospitals in terms of the drivers of performance there. So there's a huge amount of work going on within our hospital walls about making sure we're clear about when patients are ready for discharge. We do everything that we can to make sure that that happens in a timely way, and we continue to work with our partners in the community and with our social care partners around the patients who need onward care after they've been with us and the very significant issues we have on occasion with discharging those more complicated patients to where they need to get to. And with that, I will hand on the baton to Tina to talk about elective care, but I'm very happy to take any questions at the end.
We'll go through them all and then we'll take questions on all of them.
So, I'm Tina Benson, the Chief Operating Officer at Hillingdon. So just cover electives. So overall, brilliant story for us, both nationally and locally, with Hillingdon and Chelsea really now focused on their 52-week waiters, mostly cleared 65 and 78, and London North West and Imperial, whilst they have some patients over 65 weeks, they're also in an improving position and continue to reduce very specific issues at Imperial, which I will mention because they're not easily solved, and they are neurosurgical patients for which there is no London mutual aid and certainly no sector mutual aid. We are continuing to do mutual aid to clear all our longest waiters at an APP where we can clinically and appropriately do that. So really good working together to make sure our longest patients are prioritised after our clinically urgent patients. We will of course now start to need to measure, given the reforming elective care guidance. We'll need to go back to actually measuring the 18-week constitutional standard, so the board has sight of where we all sit against that. We will look to do that for the next report because that is becoming quite important both locally and nationally. I will just move on to diagnostics, where we had seen some deterioration and then stabilisation. We were expecting to recover this target by the end of the year. We will not be recovering the target completely by the end of the year, and that is due to significant equipment failures at Imperial, the continued challenges at London North West around the waiting list cleansing, and we've also had equipment failures this week at Hillingdon, which we've all consistently said in terms of a risk to this target is ageing equipment, and that has actually played out. We are putting in contingency plan, including can we move staff to vacant capacity in the CDCs that we haven't been able to yet staff. And over the next few weeks, we will formulate that plan to discuss with Leslie specifically in terms of our performance lead. I'm going to pass on to James.
Thank you, Tina. I'm James Waters. I'm the Chief Operating Officer at London North West Healthcare. Good progress to report for North West London in terms of cancer. Our national position in North West London, just to give you a feel of the national position, we're 5th nationally for faster diagnosis, 2nd for 31-day referral to treatment pathway, and 3rd for the 62-day treatment pathway. So very strong positions nationally, which I'm pleased to report. Faster diagnosis across the collaborative exceeded the standard. The same is applicable to the 31-day standard. On the 62-day standard, the collaborative exceeded the expected 70% London performance, and it was good to see 2 organisations in North West London both achieved the 85% performance aspiration that we've set for ourselves to be one of the best cancer performers nationally. So very strong performance in cancer services overall. Thank you.
Just to add to that, actually, I did get a note from to our partnership with Royal Marsden to say thank you, because the whole of the performance of that partnership is one of the best in the country, and that was in no small part because of the efforts of all the partners in North West London. So collaborative, so really well done.
Great, well done, thank you.
So I think what you can see, everybody, is a lot of hard work going on, always more to do actually, but we should take any questions.
Any questions?
Simon Morris, NED, London North West and Hillingdon. It's good to see the number of patients ready for discharge declining, but there's still nearly 700 people in our hospitals who shouldn't need to be there. What more do you think we need to do, or can we do, to get that number down? Because if we get people out the back door we can get more.
So there's a couple of things, well, more than a couple of things that we're doing. So actually, all of our crews that sit here come to the flow board. So we now have North West London Flow Board, where we have all our partners, so mental health community, local authority, and our ambulance trust as well. So there is ongoing work, and we go in detail by borough, by provider actually, as to what is causing those delays. The other thing we're looking at is not just the numbers of delays, but the delays by pathway, by borough, and by length of delay. Because some of them are literally a half a day, and some are many days. So we're getting into a lot of forensic detail. The ICB are also there because, of course, there is a commissioning responsibility here that says, have we commissioned enough capacity in the right places? So, and it is not just a North West London issue, it's a London and a national issue as well, but people are working very hard at it. But the other issue, and our local authorities would say this, is that they do everything they can do within the funding envelope. So I think there's another discussion that's happening nationally about funding envelope for social care.
Would you say that funding remains a critical issue for social care?
I would say it definitely remains an issue for this.
Thank you, Lloyd.
Hi, I'm Lloyd Lobo. I'm a non-executive director at London North West at Imperial. I had a question regarding the waiting time for diagnostics other than cancer, which is still higher than our target. With the CDCs coming on stream now, what is the expectation when they will be performing at full capacity, and what is our aspiration for when we will achieve the target for diagnostics?
Yeah, so in terms of the CDCs, we're actually over-delivering on the expected activity in terms of our plan. We're just working with the centre to look at our plan for next year because they are directly funded, and we're hoping that will continue into next year given the reforming elective care announcements, because obviously that may not be the case in the acute organisations. We need to come back with a plan to deliver because obviously our plan has been completely taken off track by the unexpected complete failure of particularly one of the MRI scanners at Imperial, which will not be repairable. And we'll need to just come back with a plan for our local performance committees, and then to hear, I can't answer that question right here and now because it's just happened this last week.
Thank you.
Anita Manchanda, Hillingdon and Chelsea Westminster. Just on the elective list and the elective recovery, just wondered to what extent the elective orthopaedic centre is feeding into those improvements, and where are we with the plans for increasing the throughput? The third part is what will be the impact on productivity metrics if we add the EOC operating at full capacity?
I don't know if Pippa or James might be best placed to.
James, do you want to come in?
Yes, thank you. So we've achieved our recovery trajectories, which were all about increasing the amount of patients that we can see in our elective orthopaedic centre. That's had a really positive winter, perhaps bucking the trend for other services where emergency pressures have crept in and limit our ability to always deliver the timely care that we hope to. The OC hasn't faced any of those pressures, being on the central Middlesex site. And so all partners have benefited from an area that can continue to use good efficiency and productivity to deliver the best possible outcomes. We set ourselves tough trajectories to increase the amount of patients seen through that model, and patient feedback has always been incredibly positive, and we are staying well within those trajectories. We now need to turn our attention to what we think we can stretch ourselves to next year. That has to be realistic, but again, stretching to get the best possible utilisation of that model. And we're tracking the North West London performance against our patient tracking lists so that there is benefit across the collaborative in an equitable way for patients accessing those services.
Thank you. So I think we'll work very hard at that, and we will work very hard at our elective productivity. The slight caveat is, of course, is that we're just working through what the finances around DRF next year will mean in terms of what we can do, what we should do, and what we can afford to do actually. So all of those things, yeah.
Yeah, I just wanted to pick up the point on cancer, and so 28 day, 31 day, and 62 day. I think it's good to hear. I guess a couple of things for me. One is sort of a concern about the invisible, the backlog of patients who haven't quite gone to the healthcare providers. So how we work with our external partners and other healthcare providers to make sure we try and catch everybody that we can catch. And the other question was really around the sort of inter-trust challenges we might have. So things we're working on with each other to make sure that transfers are happening seamlessly.
So I think, AJ, you're alluding to the right thing, but it's outside of this group. So the ICS have a work stream around prevention and a work stream around inequality. That is the two areas that we are picking up the work around patients presenting to their GP late or not accessing screening pathways. And we know from the national data and from West London data, there is an inequity that plays out on that. Some of the work that we've been doing that Carolyn and Anita are chairing around the equity EDI work for patients is picking up on this. Where do we stop as an APC, and where do we then just allow the ICS to take that work forward, because that is a system approach, and what can we influence as an APC, what can we do as an APC. So we'll bring some of that back, because we touch on that when the APC work that we're leading. I think the second bit, the inter-trust referrals, is not an issue. We have that, we've got that above and beyond now in terms of not just individual patients, but mutual aid, as Tina alluded to, where we've got long waiters, we're sharing long waiters across the trust, so we can prioritise our longest waiters or our most urgent patients first across all 4 organisations. So that bit is seamless, I would say. To be honest, as a chief exec, I don't even know it's happening. Sometimes the COOs just sort that out themselves and are managing their patient lists in that way, which they rightly should be.
Thank you. Can I move us on to finance?
Yeah. It says anything by exception. There's quite a few exceptions actually, frankly, but I think everybody is well cited on them. So we continue, and Jazz will do the details. We continue to have financial pressures, which will do the detailed conversations about cash continue actually, and Jazz will do a little bit of the detail, or one of the CFOs will do a bit of detail about I&I. But again, they put a lot of work into this to try to, for us to, the first thing is really understand the position. Can we understand what we can do something about? And the discussion with the ICS is ongoing about what could be bridged to the year end as well. Jazz, I'll leave it to you to orchestrate.
Thank you very much.
So I'm Jazz, then I'm CFO when I was any questions, direct to anyone. In terms of the APC, what you have in front of you is the financial position at the end of November, which was month 8. At the end of month 8, the APC as a whole reported an actual deficit of £35.2 million. 57.2 million now, as you know, those recovery plans and then
oh, there we go, back again.
So those financial recovery plans are being monitored very closely, and I think if you look at the in-month position for November, actually APC has a surplus of £4.5 million, which is marginally behind the recovery plan. Actually does show that we are actually coming through, and actually the small deviation in the position as well. So there's some catch-ups that we'll see later. At present, the APC as a whole is forecasting a break-even position formally, and that's every month we have report up to NHSC about where we think we're going to land. However, it is important to note, and the paper does set out, there's been some more detailed conversations internally about what the realistic position may be, given some of the pressures that we're facing within the sector. And the basis of that calculation, and this is at month 8, and we know we've got month 9, month 10 discussion ongoing. The forecast is actually looking at position across the acute and that primarily falls in 2 organisations, and that is Hillingdon and London North West. They are subject to review and update, and we'll in terms of cash, as Leslie mentioned, that really does still remain an area of concern. And in the Northwest, if you look at the cash detail, have to have cash support every single month in order to make their commitment. So we are working wherever possible to try and make sure that that is a position with control. And the idea is to prepare today as well, also into those conversations with the national team about ensuring we get the cash that's coming into the system. In terms of capital, all of us have to meet the limit, and actually at the end of November we were underspent by 28.7 million. This is partly a phasing issue and it relates to technical accounting of Article 16 leases, and the calculations do show that we will cover that position. They're not a risk, but definitely a timing issue that we need to be mindful of. And obviously for Imperial in particular, given the announcement of the hospitals programme, we need to be reassessing the redevelopment costs that we would have been assuming funded for the financial year. That's where I was going to pause in terms of the month 8 position and forecast. And I think questions we can
yeah, let's do the now question. Just so that we're clear, the report on forecasts that goes to the national team comes out of the ICB, not directly from us. So our position at the moment is minus 50 million. The ICB is still working on its number, so it currently hasn't moved away from break even. Is that right?
No. Each organisation has to make its own financial return every single month. So the financial schedules that go in there at the moment show a break even for each of the 4 organisations. However, there's a commentary that we provide alongside that does state that the unmitigated position, if some of the risks materialise in the way that we think they will materialise, with 2 organisations saying their respective numbers would not be break even. The convention is that once you're in INI, you don't change it till you're during the INI process. That should help. It's a bit more concrete.
Yeah, it's just capturing as a board what we're telling the board the position is, as opposed to the process and the convention in terms of what's reported. And I don't want the board to misunderstand what we're saying.
Yes, so from the board's perspective, at the moment we would be forecasting 50 of the APC. And apologies, I should have said actually that deficit position would be the deficit position for the ICS as a whole. We are the only ones that would be forecasting not being on plan, which would have been break even. That has instigated the investigation and intervention regime, which means we're in segment 4 in terms of the oversight programme, and that means we've been appointed a firm and an NHS to review of the financial position to see if that £50.1 million is the best, most realistic position that the APC would get to. And that review isn't just the acute provider, we've also looked at all of the other organisations. There's more that we've had to respond to a copious and very detailed amount of questions over the holiday season, so a huge thank you to teams that have had to support that. We are now awaiting feedback from that process to obviously answer any responses and questions. Their task really in this instance is to validate the position, and then the secondary task is also to think and help us about our 25-26 planning, where there's any learnings around what we could be doing differently in order to make our financial position more resilient and our operational position more resilient into the future years. So it's 2-pronged, but there's now there's a future bit.
Thank you.
Mike O'Donnell, Ned at Chelsea and Westminster in Hillingdon. And I get that this is convention that I don't yet pretend to understand, but that it does feel quite uncomfortable that we're making a submission, even with footnotes that say don't really believe it, but that we're forecasting break even. I guess that is what it is, because I'm not sure I'd be very comfortable in signing that off. Glad I don't have to. But the INI timeline, my question is when do we get to a point where we can resubmit a forecast? that is perhaps a bit more realistic, which is about the I&I process coming to an end. So when does that happen?
Do you want to jump in on that?
Yeah, it would two things. One is just to reassure you, there is no, is everybody well cited on the position? Absolutely. I mean, we're talking about it here in arena. I think the timeline, I actually, Jazz, you.
And Mike, just to reassure you also, although the formal reporting is of a particular type, the conversations with the ICB and the national team have been going on to just cite them and bring them up to speed about where the indicative position may land. So it's not going to come as a surprise to anybody at the national level. Just wanted to reassure everybody of that as well. And in terms of the I&I process, we think by the time we do month-to-month reporting, which is the end of January, early February, that's when we should have a conclusion about formally putting our numbers out there that would have validated if it's the best position we can get to, or are there opportunities to make that number lower, which is the absolute job we're all trying to do between now and then.
Helen Stevenson, Ned for Imperial and Chelsea Westminster. Just a question to the chief execs. How is this going? How are you handling this with your staff? Most of whom will have had a kind of degree of already kind of pressing down on finances over the last year. So it's not a new, it's very dispiriting, isn't it, in the sense that you've already been trying to control finances and now we've got this increased procedure which make it even more difficult. How is it going and how are you mitigating the workforce kind of demoralisation, really?
You want to skip first?
So, I mean, I've talked from the organisation, it's probably got one of the biggest challenges. I have to say staff have responded very positively. You know, we've got vacancy control panels in place and not a single post goes out to advert until it's signed off on a Friday. Vacancy control panel, many of them are rejected and asked for further information, and staff have responded very positively to it. They are very on board of understanding that to be, you know, an efficient organisation, money is part of that. Quality clearly speaks aloud. We're always very clear about, but you know, you have quality without the money to back that. So staff have been very engaged with the budgetary controls that we've put in place. Last month at London North West, we gave them a temporary staffing cap. So, and they've lived to that. So every single ward manager for every single rota has an agency control cap that they've had to live to, and that's what Don has put in as a measure as an interim CFO to reduce our bank rate as well as our agency rate, and they have very much lived to that. So I think by giving them some controls and giving them details to work to, actually they've delivered it in a very positive way. I would say, I was going to say, this is nothing new. This is nothing new for us. How we work.
Did you want to add something there?
Yeah, I don't want to be the party pooper here. So I think people have responded. People have responded. I think we all have to be absolutely realistic that we are about to engage on a step change in the ask here. And I think, you know, we don't know. And you know, as Pippa said earlier, we've all worked incredibly hard to make sure that the people metrics have improved over a period of time. And we have all got to try really hard to make sure that we don't lose that progress. And I think it's one of the reasons I made the point about productivity earlier. You know, it's our job as leaders and it's our management team's jobs to put in place a system that allows our clinical staff to do the job in the most efficient way that they possibly can. And that's where we've got to put all of our effort in the next couple of months in the run-up to 25.
So we should just bear in mind that we're talking about 50 million on a 3.5 billion pound turnover across our organisation. So this is about 1%. This really is a fine example of the NHS landing a jumbo jet on a postage stamp. So these are really, it's really important that we break even and we only spend the money that we give them. But we're talking about margins on absolutely enormous budgets here. And for the 30 years I've been in the NHS, we've been doing this because all of our staff and everybody in this room wants to deliver as much care as they possibly can, which means you never leave any money on the table. You spend as much as you possibly can, and then we're constantly reining people back in to not do more than we can afford. And that is the nature of being NHS.
I agree, Matthew, but the I&I process doesn't feel like that. It feels like, you know, they're touching over the head with the stone. So although it may only be 1%, but it feels like they're dealing with us as if it's 20%.
I'm going to come up to Nick.
I just wanted everybody to remember what you've just said, Matthew, when we start to have the conversations, because we will start to have conversations about what really big schemes we're going to do that are going to deliver massive change. And actually, I think an awful lot of this will be delivered by everybody doing a small amount. There will be one or two big things, but I think there's always, when we get into the conversations, there's always a sort of drive to do the sort of big dramatic stuff. And actually, I think a lot of this at the end of the day is going to be about good management and good leadership.
So I'll let some other people make contributions, because the Chief Executive will no doubt come back several more times during this conversation. So, Nick.
I was going to make a comment about capital. So if David wants to talk about the INE stuff.
If I could, thank you, Nick. So could I just understand, so we've got the current period of INI, which hopefully is helpful and produces some things we didn't know already. If I'm honest, I'd be surprised, but it could do. What's the longer term situation for the 4 trusts that are in INI? How much scrutiny, how much interference, how much control is taken away from the executive teams to be able to run their trusts?
Just do the, because you did mention what the timeline was, because it's come to an end.
Yeah, so the INI process as it stands at the moment, David, is time limited. It's very much about getting us to a 31st of March position. We're not the only system in the INI process either, so there's a number nationally. And then hopefully it'll give some insight into what we could be doing differently for 25, 26. It's not deemed to carry on forever and a day and take powers away or decision-making away from organisations. However, we have got to go through a planning round for 25, 26. And we do need to understand what our income assumptions will be, what our cost assumptions will be, what our efficiency challenge is going to be, and do we as a system land on a break-even position or not? That may bring a different type of scrutiny across the whole of the system and across our area.
But that, just to be clear, that hasn't yet been put upon us. Thank you.
I'm going to take 3 more comments, then I'm going to let Leslie wrap this up, and then because I'd like to move on to talking about next year on this year, if that's okay. I'm going to do Pat, Benita, and then back to Nick.
Oh, thanks. I just thought there was one point I didn't see in there is this process of an INI and the consultants is costing us a lot of money. So I think we've always got to bear in mind, because we didn't land it, we've got costs. The second bit is, and I know people are working on it, but as a collaborative, hopefully we can start looking at more things that we can do once rather than 4 times for the future, that can start really saving us money. Except there's always a start-up cost for that, but I think we should use it as an initiative to actually do more rather than less in that area.
Thank you, Benita.
I just want to talk about the Hillingdon elective, where I think you're saying we were doing less in the month, and that made things adverse to forecast, and we were going to recover that, if I understood that correctly. Just want to understand what's happening, because there are different views about whether that helps our productivity or doesn't.
It's not linked to productivity per se. It was a recovery action around how activity was being coded and what buckets it was being coded into. So what the work was to do was make sure that activity is coded appropriately, becomes elective by nature, and therefore attracts elective recovery funds. What happened at the end of month 8 is that work hadn't quite completed and caught up, but in month 9 it has, and it's switched between buckets.
Okay, so the debates about that work not being possibly profitable because it's cost. That's a separate
That's a different discussion. Nick, then Carolyn.
Mine was a more technical point around the capital thing, and I just think it's worth for the public and board members who haven't lived IFRS 16 as we have at audit committees last year to reflect the fact that there is that impact on our IFRS 16, which is explaining the capital underspend. I think it would be very quickly explain what that is to our colleagues.
Okay, so this is where we have technical accounting guidance, where things that were leases were on the income and expenditure account have been lifted and shifted across to the balance sheet, and then the cover for that has been moved across to the balance sheet as well. So it's just about how we account for leases on the balance sheet versus how we used to account for them, which was on the income and expenditure account. But the technical work around making sure you've got a lease in place, it's been agreed, you understand the terms and conditions, how you account for it, has been the work that's had to be required to be undertaken in order for us to do the technical accounting.
Thank you. Carolyn.
Yeah, so when this I&I process, so when will we as a board see anything that's coming from it? Because everybody talks about it all the time and it's been in place since the 20th of December. As a non-exec, I know nothing about it whatsoever.
It should, in the first instance, come through each individual trust's committees, if I'm honest, and then it should go through the APC, FMP, and then ultimately come up to board, but it may go to cabinet as
So
well.
will it come to the round of committees start next month?
There's one in Hillingdon next week, I think.
We won't get an up.
We'll have to take some sort of an update, but we'll be able to. Right, Leslie, do you want to wrap this up?
So we're getting closer to understanding what the financial position is. We're in discussion with the ICB that says, what's the figure if we can land it can be bridged for this year? That will lead into where we're going to go in a minute, which is the discussions. I think Helen's right that there is a regime, but actually you would not expect, would you, for there to be nothing to be done where we have these sorts of levels of if you like, projected overspend. And I think it is designed, this bit is designed to be as helpful as possible. And so we've taken it in that spirit. Thank you.
Okay, thank you very much. Do you want to take us on to the planning?
So as everybody probably knows, most of us have been planning for about 2 or 3 months now, trying to understand, with no national guidance having been published, about what planning would look like, what the assumptions we need to make, both jointly across the APC, but also across the ICB, to make sure that we're developing our plans in a way that makes it easy to tweak those at the point that the national guidance is published. And what this paper tries to set out is initially it sets out what North West London ICB sees as its strategic planning assumptions about where it wants to focus, and it wants to focus its attention. So we've got to be mindful of that as we develop our plans. And then across the APC, what we are doing in terms of making sure that we're developing our plans in a more aligned way. And there are things, submission and assumptions that we've included in the paper around making sure we understand our operational demand and capacity modelling, so we're clear about what have we got, how do we make sure we meet that demand, what's the workforce requirements to meet that demand, and how do we make sure we're getting the best out of the resources we've got, how do we review and reset our funding arrangements with the ICB to make sure that our cash envelopes are explicitly clear about the activity that's being purchased, the price at which is being purchased, and what does that mean in totality in terms of the income we will receive. I think this very much talks to some of the discussions we've had in 24-25 around there's certain elements of our contract which are cost and volume, very easy to decipher. There are things that are blocked. I know each organisation's had issues around overperformance in certain areas. What we really like to do is set a baseline that we feel buys the level of activity that we will be delivering in 25-26 and being explicitly clear about that. And I think most of us will not be signing a contract unless we resolve the contractual issues we've also had with the ICB funding arrangements in 24-25. So there's a lot to do, I would say, in terms of agreeing an envelope that we feel allows us to deliver what we need to do. Now, alongside that, we've obviously got to test our cost base, because the difference between that envelope and the cost that we will be incurring will lead to an efficiency target that we will need to think about plans to deliver. And I think to Tim's point, there may be 1 or 2 big schemes in there that we've really got to kickstart and start to think about what that does for 25, 26 and beyond. So it's not an annual process. We've really got to start thinking more longer term. But then also, what are the small things that we are going to have to ask our staff to think about every single day as they make their decisions to save money. So there's going to be, I think, quite a detailed conversation about our efficiency opportunity, which then lends itself to the productivity questions that we were asking earlier. But how do we determine what good looks like for productivity left? So when you have a workforce of X, you have an activity model of Y, how do you get those two to be the most productive they can be in a constrained financial envelope? Because there will be no new money coming into the NHS in 2026. In fact, it's a real terms cut. So we know that the challenge is going to be pretty big. And the key thing we're also trying to do is make sure that the triangulation between our activity plan, our financial plan and our workforce plan is aligned. And there is a model that will test that as we go through the planning process. Where there is misalignment, we have to go back and revisit those numbers and try and understand why there is a disconnect. That's what the question tells us. And there's a reason for why that may be the case, but we do need to make sure we can respond to that. The second bit, and another big bit of our planning, is obviously around capital, and we know that our capital limit is also coming down for 25-26, but there are some national initiatives which I've included in the paper where there may be some more funding available that we may want to bid against. The bit we cannot forget is that capital is not free. It generally has a revenue tail. So when we're talking about the revenue plan, we've got to be very clear about what revenue implications that capital plan will have for that revenue plan. And we may need to think differently about the decision we made. And tie all of those three things together, cash planning. I think the one thing we are very clear about is we've got to make sure we're triangulating all the planning in income expenditure terms and capital. What does that mean for our cash balances? And how much cash are we going to be deploying in order to service those plans? Because at the moment, given our cash positions in each organisation, and I would say, without talking out turn for Chelsea and Imperial, on the face of it, the cash balances that if we don't be mindful of those decisions, we could end up in a similar position with other organisations. So we're just trying to make sure we talk about cash just as much as we talk about income expenditure, just as much as we talk about capital, and not leave that as the last thing that we think about. In terms of submissions, our understanding is that the national team are looking for a submission on 27th of March. The timeline for doing all the due diligence on those plans, making sure they're as robust as they can be, being through all the governance points that need to go through. It's quite challenging here and now. So we'll have to think about that as we work up the timetable, which I know Peter will across individual NWC and ICB. And just to finish off, there are a couple of submissions on the 6th of February and 6th of March. Those dates may move, but that's what we're told. But I have included in the pack the elective care reform plan that was published. That does give us some indications about what they're going to expect in terms of elective recovery. And I'm assured the recovery fund will be that. So nationally, they want to deliver 118% of value-weighted activity against 1920. How that falls to systems and how that falls to providers is yet to be determined. But I think it's very clear there will be little or no overperformance funded next year. We've got to make sure we right-size our cost base to deliver that level of activity that will be required of us. Sorry, that was a really quick counter through.
Did you want to jump in?
Yeah, just on the back of what Jazz was saying about the business planning process. As I say, the expectation at the moment is a submission of 27th of March. But when the planning guidance comes out, we'll be clear in terms of what that process looks like. But we have mapped out that governance process to get through trust level approvals, and each of the individual plans will need to be approved by each of the individual trust boards, and then the collaborative version of it as well. And it's just that is tight in terms of a timetable. So I guess it's a pre-warning. We may need to set up extraordinary meetings as we go through this next process to try and get through some of that.
Can I just say also that not having planning guidance now and then having plans being submitted on 27th March is madness, because those plans will include a load of things that we're committing to do to deliver next year's plan. And if we don't start working on them until the 1st of April, that's the first call I've written off to start with. So I would urge the things we're obviously going to have to do next year. Let's make sure we're doing the work on that now, because every year our plans suffer from the fact that we have a cost improvement programme that has 3 months dead time at the front because of these sorts of timetables.
I think there's been much more of an assumption this year that we will have gone through all of those other governance things. So by the time it goes in on the 27th to the national team, we will have done all of the things that you would have expected us to do, and that the ICB have signed it off, so it's going in more or less. Hence, we absolutely have started it, but there's a lot of work to do right here, right now.
So, questions, Martin?
Yeah, I don't know whether this is a sensible question, but when Tim talked to us at the beginning of this meeting, he told us that there was a very real risk of one, if not two, of our hospitals essentially stopping functioning because they are so dilapidated. How do we monetize that risk in our plan moving forward? Because essentially the plan assumes that everything is going to be running at full tilt, when we've just been told that there's a high chance that we won't.
Tim?
It's a very good question, Martin. And just to throw in another bit, we had a piece of work done at Imperial about 10 years ago that looked at what was the cost on the day-to-day running costs without everything actually breaking. And it was tens of millions of pounds. So you've got, in addition to the risk of catastrophe, you've got inbuilt inefficiency because of the state of the estate. We have to assume that we are going to be able to run our estate, essentially for the entire year. We make some allowance because we know that's not going to happen. So, but we don't know where and when we're going to encounter the failures. So as Tina said earlier, you've just heard another one of our antediluvian MRI scanners has given up the ghost. There is a real problem. So we have to plan with a degree of contingency built in, but it's to a certain extent finger in the air.
Can I? Go on, Helen, and I'm going to wrap this.
We just, when we talked about this over the last few months, the thing that seems to me to be driving all of our you call them overspends, I don't know what you call them, but it has been the fact that we're not paid for the things that we've done. We're doing more than we said we were going to do at the beginning. Are we putting our activity levels in at the real world activity levels, or are we putting them in as to what we think we've been funded to do? If we do the latter, we're just going to end up in the same place again next year.
Oh, that's it.
So we will put them in at the activity levels that we believe that we will do. I mean, there is a funding formula. There has been a funding formula for the 100 of years that I've been sitting in, and it doesn't always work completely, but there is something, and next year, and I don't know if we how much we pick this up, there is a discussion about the payment for the emergency workload and what we're going to do with that. I mean, that's been an issue this year. But the likely impact of the increase in the emergency workload payment has led to the discussion about the capping of the elective work payment. That's the bit that we need to work through, that says there is work that we will have to do. It's emergencies and it's the cancers and whatever. There is the work around getting the waiting list down to 65 or 52 weeks. And then there's the bit that says, and that may be all that we can afford to do. That's the piece of work that we do.
Sorry, I'm sorry, like echo what Liz just said. The non-elected block, essentially, we've all over for the block. We will negotiate an uplift to the block for next year based on what we think we will deliver, we hope. But of course, unfortunately, because we've got a lot of unearned income in our baselines, what that will do is turn unearned income probably into earned income for next year. We've then got a series of calculations to do around the elective activity, which says we'll be paid up to 118%. What do we think we need to do to meet the waiting list targets, which are to deliver a 5% increase in your 18-week RTT performance and eradicate your long waiters? And then do they match? And then the final thing we've got to do, of course, is we've got to stop using premium time to do elective work if at all possible. So that comes back to giving our job to provide a system where people can be as productive as possible. So we pull as much work out of premium time and into the normal working week. But those are the calculations we're going to have to do, and that's why when the planning guidance become really key to allowing us to work out where we are.
That's why he's a professor. I'm a
So when we hey, Leslie,
you're doing all right.
Yeah, I think when it comes to signing off the plans, the most contentious bit for the non-executives will be, do we believe the activity that we're being paid to do is credible or not? Because we don't think it has been this year, and most people forget some details, I would say. So so I think the challenge is there, and then the question back to the executives is, that's the activity. What are we going to do back to do that amount of activity, particularly in the emergency space? If it doesn't reflect a year's worth of 6% growth in ambulance arrivals in next year, then at what point do we say, well, we're going to take ambulances for our own population? You know, we're going to have to get crunchy about this. Otherwise, we'll be sitting here this time next year. We then have to deliver our deal on productivity, and our deal on activity, and our deal on cost control. Those are the two halves of the question. Can you keep that to yourself, Bob?
I'll be quick. I just want to amend your thing about non-exec. I think there's something else, and that is those things which we entered into in good faith, looking at system work, which this year has failed spectacularly. So it's more than just, are we being paid for the work? It's, are we entering into arrangements which are held to? And what's the robustness of that? Because it can't be the 24-25 definition of robustness.
I know you feel close. Did you have a point you wanted to make?
No, the question, I don't think it needs answering here, but I was interested, and I think it's symbolic to that element of it. I'm just understanding better the split in the electric tariff for this advice and guidance thing, and what we think the implication of that is going to be, either in terms of reducing demand, increasing pressure on consultants to be on the phone half the time to GPs, and what actually that's going to mean. Now, we can cover that going forward, but I think
we park that until we've actually got the planning going. There's a lot of contradictory stuff come out, so
Hopefully soon.
and we'll know from the quite soon. Thank you. Okay, so now I'm moving on to Carolyn. Anything else you wanted to raise from F&P?
Absolutely nothing.
Thank you very much. Okay, moving on to the Digital and Data Committee report, which it was my enormous pleasure to chair for the first time, post Steve's departure, and also it was Robbie Klein's first meeting as our new collaborative-wide head of. We've got the notes here. I think the main point of concern which the board needs to continue to be aware of is our concern around cyber risk. Both there's a huge amount of work going on both to secure the systems we have. It's now extending out to making sure that we are confident in the security of the major key suppliers, and that's a big piece of work that's going on at the moment. And also now starting to turn our attention to what happens if something does go wrong, because however brilliant you are around cyber security, you can't guarantee that nothing's going to get through. So that's you're all aware of, the audit committee is aware of that as a risk. Are there any questions about data and digital? Tim?
Probably just worth noting, and thank you, Patricia, for her work as the lead CEO in digital and data, and I'm going
to note and thank yourself for agreeing. I note and take it. Thank you for that. And thank that Tim has agreed to take on the lead chief executive of the data division. Thank you.
Just to comment, I think most of the audit, which is next year's internal audit plan, so including something on cyber security at suppliers. So I think this is a question we need to pick up at the audit committee collaborative, because we're doing 4 separate audits. What's the commonality? Are we standardizing the terms of reference? Are we paying for the same thing 4 times?
It's a good question, and I'd like the audit chair to take that away, because we have a number of systems that are common as well. So
I think the internal audit just taking money.
Thank you. Very helpful. I'm going to move on to the Estates and Sustainability Committee. Bob.
Hi, I'm Bob Alexander. I'm the Vice Chair at Imperial and Ned at LNW, and I chair this august body. Look, I hope the paper is eminently self-explanatory in the context of the item we started, where we're explicitly talking about the escalation of backlog maintenance across the APC. That brings in the start relief, the announcements from yesterday. So that's what we're turning our attention to in the next cycle, as we would expect the contingency planning in certainly Imperial will have to be refocused in the context of like that. I think it brings all mark when we start talking about strategic capital planning against the backdrop of elongated backlog. That's something for another day, but just to lay that here for things.
Thank you. Are there any questions? And then we have the time in terms of reference. Questions for Bob? Oh, thank you. Yes, we also now need to agree there is an updated set of terms of reference, which are helpfully track change, so you can see what actually changed. And you could see that this is the committee which has discussed this and are in support of it, is recommending that they also pick up conversations about the relationship between capital and productivity going forward, which ties into a point that Jazz made about us having to make smart decisions about how we spend our capital, the consequences, and looking at major decisions across the collaborative, so that we're joining up. Is everybody happy with those terms of reference? Okay. I'm going to take that as wild enthusiasm. Thank you very much indeed. Sorry,
But the miking is very poor. Yeah. But it's not just the miking, it's the camera work is amateurish.
Make sure they have
It goes funny, fuzzy. The guy doesn't know how to make a transition.
Jim, you're not on mute.
That's the way to do it. I mean, Imperial, we've got the estate read on our risk profile, but it feels to me that that's gone up even more now, and there's a risk that we will lose one of our sites because of the delay in the procedure, the programme.
There's going to be one for.
And then that now.
Well, we'll pick it up at the next trust standing committee.
Yeah.
And what they would like them to talk about the trust there.
Sorry, can I just add a point onto that? I mean, obviously yesterday's news for Imperial was not good, but it doesn't change the immediate challenge. It changes the longer term challenge. So I think any issues immediately are still as they were.
Yeah,
the state is still in its same condition. It's just it won't be done in 5 years and maybe done in 15.
Yeah, if we had been delighted about our announcement, we'd still have 6 years worth of risk to cover. The risk is there. Yeah. Thank you. Okay, I'm going to take those terms of reference as agreed, and I'm going to move us on to Tim's update from the Executive Management Board.
Thanks. I think you'd be unsurprised to hear most of the things that we've discussed at the APC EMB are the things that we've talked about at this meeting, which I guess is in some respects reassuring. I think a couple of things to highlight. I think we do keep an eye on the clinical pathways work that we have. So, yeah, as you would expect, there is some variation in enthusiasm between different clinical specialties, but by and large, clinical engagement has been really good. I think that there are going to be some very interesting things that fall out of these pathways, some of which will be entirely expected, and actually some of them probably slightly less expected. Obviously, in terms of oversight, there will be the pathways that Patricia and her team had been overseeing, and Leslie has very kindly agreed to look through those and try and work out what the best solution is for each of them, because obviously if the team from Hillingdon has been supporting, we don't want to move them to another chief executive and another whole set of execs. So she's going to work through exactly how we plan to handle that. It's a fantastic side pass from me to which is very good. Otherwise, I think you can see we've been keeping an eye on a number of things of interest across the collaborative, non-emergency patient transport being one, Deptford Feeding Centre obviously being an issue that we are trying to galvanise our colleagues to drive. That now seems to be working well. And then I think to the point about the big projects we were talking about, I think we are very keen to get a grip on what are the things in terms of the things that we should be doing once across the collaborative rather than multiple times in the non-clinical area. Only thing I would say, just to sort of highlight, at our next joint executive group, which is subtly different and even more exciting than the APC EMB, we will be discussing, I think, what our approach to the enactment of our strategy is, given the pressures that we can see coming forward in 2025, 26. I don't want to be here promising that we're going to do a gazillion things when only we can can only do half of it. So it is important that we have that conversation as group of execs and come back to you and say, this is where our priorities will be at 25, 26.
Thank you. Nick?
Yeah, and on the joint projects, Tim, you're aware because you were at the meeting that we had a couple of audit reports in Imperial focusing on some of the challenges that the organisation historically faced in delivering benefits realisation and procurement. So it's just hoping that those lessons we learned and what the sort of mechanism for monitoring approval, which I assume will be through the collaborative committees, for assurance that we're getting these business cases right, that are identifying appropriate business right realisation, because obviously, you know, we're each, I suppose, technically will have to separately approve for each organisation, but we need to make sure there is a collective monitoring assurance that we've got that with appropriate discipline and approval, that we're getting it right.
I think that is a completely fair observation. The only thing I would say in our defence, of course, is the North West London Procurement Service is an ICB-wide, not an APC endeavour. So I think we will have hopefully a little control.
And in terms of the sort of second, well, I have the floor. I mean, we made the point about just now about internal audit being shared, and the way the process of internal audit tends to come is that it comes first from executive, and then there's a proposed plan which then goes to audit committee and committee chairs. So just to ensure that your collective bodies, be it the executive collective body or the EMB, it has a sight of that audit plan, so that the executives, when they bring it to the individual audit committees, have also shared it. Because rather than us going back and saying, can we share as a reference, make sure that you have sight as an executive about what you on and where it's appropriately shared.
Again, I think that's very helpful. The thing I would say is I think we need to be very clear about the things that we do want to do to get that. And with cybersecurity, I think is a very good example. But also, I think while we still have 4 sovereign organisations, I'm very clear that audit within that organisation is key function. So I think it's, as you say, it's having absolute visibility about what are the things we want to standardise across the 4, what are the things that each individual trust is going to do.
Thank you.
Sorry, CFO at Charles West. Just in answer to your question, Nick, about corporate services and procurement, just to advise that we've got a corporate programme board that's reviewing both benefits realisation from any existing pieces of work that we've done, but also to inform the future projects. And then each project individually will go through the appropriate governance for depending on value as per our scheme delegation. So we do have a process to do that.
Thank you.
Just on further on governance of these key collaborative projects, great that there's a programme board. Where does it get up to a non-exec committee or something? So, for example, the elective orthopaedic centre, we hear in general about something that I've not yet seen any detail, metrics of productivity, where does that land? And if it doesn't, there
are 2 bits to this. The running of the elective orthopaedic centre sits within London North West, and it reports through the London North West Trust Board processes. The overall performance of the EOC is obviously of vital importance for all of us, as indeed are its finances ultimately. And that comes up through the APC EMB, and it will be reported up by exception through the normal.
The report at the last meeting of the finance.
So it comes from finance report.
And I get to see it regularly at the London North.
No, thank you. Okay, so I'm going to move us on to chief executives and vice chairs. So chief executive reports and vice chairs, standing committee reports. So Pippa and David, you're at.
Okay, so you've got the report there. I'll take it as read. I'll start by thanking staff. So you'll all know that hospitals are very pressured, acute hospitals after Christmas. We ran a perfect week for 2 weeks, focused. We cancelled all non-urgent meetings and focused completely on flow and discharge before 5 o'clock. It was a real success actually, and a great engagement from staff that really did help with flow and capacity through our hospitals through them 2 weeks that will continue a lot of the work and the learning. Some of the positive that we've done in the time, so we've opened our new emergency department at Northwick Park that now goes up to the age of 18, and we've linked it with St Giles Trust. So they run a psychological support for our children looking at youth groups, violence and exploitation of support services. So it's the first time it's a medical and psychological service running through an emergency department for children, which is really exciting. We've got JAG accreditation on the Ealing site, which is the first time that has ever received JAG accreditation. Really helps us now to run some of our cancer St Mark's work through all 3 of our sites, so we can now do that endoscopy work through the Northwick Park Central and Ealing because they're JAG accredited, which is great. And the other bonus that we had is we had an accreditation from the Getting It Right First Time national team and the Electrical Centre. It's the surgical centre hub accreditation. It runs nationally, and we got accreditation for that service. They're really complimentary of the service and the care that we provided in it across the system, which was really positive. Just going on to a little bit about people, really pleased to welcome Bimmel into the team. So Bimmel started at the start of January as our new Chief Financial Officer, comes from North Central, previously worked in North West London, so great that he's got networks and connections. So we're really excited that Bimmel started with us. And another real positive, it was great to be at the HSJ Awards with many of our team actually have helped us deliver on the work around creating a anti-racist organisation. We were highly commended for our work there. Just in terms of research, we've been awarded 7 million of government investment to increase our delivery of commercial trials in North West London. So Christiana, one of our consultants that leads that work, has been doing some great work around increasing our commercial trials, which so that was a great investment in our research portfolio. And then I'll just go on to some of the awards that we've been recognised for. So we opened our new maternity triage birth centre and had lots of external stakeholders at that opening, which was great. We also had the national team in to review our work around the maternity improvement programme and have agreed an exit off that programme, and all improvements have been delivered. Fantastic for our maternity services. St Mark's, they did win a team, so they won the Leadership Award for the British Dietetic Association for their work around parental nutrition and the support groups for patients. And Luxmi, our nurse consultant tissue viability, has been awarded an award for her work around skin tone in pressure ulcers, which is a really important piece of work for the population that we're providing care for. Really helps us be in the lowest percentile in terms of number of patients with pressure ulcers. So there's some of the highlights I think that we've achieved over the period, but mainly thank you to all our staff who are working tremendously hard to deliver the emergency programme alongside an elective programme.
David, do you want to?
Yeah, I just add one thing, if I may. And we said this at the Trust Standing Committee, actually. It's quite easy for a committee to focus on the things that are tough. So the pressure on emergency services, pressure on waiting lists, the pressure on the finances, etc. But actually, the list of things that the executive team at London North West are achieving, with nearly 9,000 staff, is quite remarkable. So we should be taking away some of the positives out of the 24-25 year, rather than just perhaps focusing on those challenges. Those challenges are there and they need focusing on, but I wouldn't want all the conversation to be based on that. So it's a big thank you to Pippa and the whole team for what's been an extraordinary delivery in a very difficult year. Thank you.
Thank you, David. Okay, moving on to Hillingdon and Lesbian Carol.
Thank you very much. So, and it's a privilege to be sitting here and delivering this actually. And you can see that actually the team at Hillingdon worked incredibly hard again during a very tricky old period. And I guess I should take the opportunity to echo Simon's words around the fact that we're really pleased that we've got to go ahead for building the new hospital and indeed its challenges that will bring. So we've got a lot of hard work to do now in terms of working together to make that affordable, because of all of the things that we heard earlier about capital charges as well. So all of that, but I'm pretty sure that we will do. I wanted, if it's okay, just to take a minute on, in a way this talks to both Chel West and to Hillingdon, to say both the team, the exec team at Chel West and all of the staff there, and the exec team and at Hillingdon and staff there, have absolutely embraced the changes that have come their way in a really positive way, which talks about maturity of both individuals and teams. And just to, in here we said we would talk as we went around any changes that came about. And I talk about these now just to echo some of the things we're talking about. So we know that we've got some pressures on teams. So we know, for example, that Lindsay leads Chel West so we're in the middle of a discussion actually with Imperial ourselves and Hillingdon around how we think strategically about our people position and what we do about that. And that was at the behest of our non-exec colleagues as well, which we took away and have taken away that conversation, and we'll bring news about that. EMA will help with the covering of comms across both organisations, so we don't have to do something in both organisations. We're doing something around the Chief Clinical Information Officer and the Safety Officer, which is actually one site is providing, we're swapping over, so there is coverage from both organisations, but only one position. Because one thing we do know is that with the financial position that we've got, that both our organisations will expect us to be looking particularly at those corporate services that says, how are you going to consolidate in such a way that actually we can concentrate on delivering care to patients. And that's the sort of discussion that we're having. But you know, I think it has been a time of change a bit, but actually we've tried to make that as disturbing as undisturbing. It might be disturbing, but as undisturbing as possible for everybody concerned. In the Hillingdon, and I should by the way take an opportunity myself to say a big thank you to Patricia in the way that she has handed over this organisation. And you will see that again, that there is recognition about individuals, and it's very interesting. You will see about Rajesh Bala and clinical engineering. It's a real strength in Hillingdon, and it's something that I think it's one of those areas that we never talk about, and yet you go and see them, and actually you see the very innovative work that department is doing around development of staff in a way that all of us could learn about, which is really interesting to see. And I know Virginia will be very pleased to see that she has supported the sustainability work, which she is very keen on. But I would say during a very tricky winter, Hillingdon has done the very best that they can do. Always more to be done, much more work to be done with our colleagues. We had that discussion yesterday, but a real tribute to the executive team.
Thank you. Carolyn.
Yes, thank you. Well, I'd like to welcome Leslie, and we're all really looking forward to working with Leslie. And we're looking forward to a positive future. And I think the announcement yesterday of the funding for the new hospital provides a different narrative for Hillingdon than there's been over the past year, which is a more positive one. So really looking forward to that and changing that narrative completely. And I too would like to thank Patricia. I thought she behaved in an exemplary fashion in terms of the handover. So, and the past few months. So I'd like to thank Patricia for that. And I'd also really like to thank Jason and his team, his whole team, and the leadership team at Hillingdon for working so hard to get the new hospital. Thank you.
You've attached to the papers the CQC letter. I wondered whether you just, apart from that, they got my name wrong at the time.
It's not all about you. I can feel my career coming to the end. So yeah, we're still waiting. So we had our. I'm trying to think if we did have the Hillingdon obvious and I'm just thinking, was it? Yeah. I think was it Chelsea or was it? So we had our SOM yesterday, and one of the points we made and that I asked the CQC is when will we get actually the report? You will have seen played out in the press that they have a problem with their IT. But I think they gave a commitment that it will be in the next 4 to 6 weeks. So we will yeah, we will.
I'd just like to put on record, I personally think it's outrageous that we had CQC in August. If there are issues that need to be rectified, that is then 5 months, 6 months later. And I personally think we should put it on record that it is completely outrageous. Sorry,
On record.
get off that on my
What I would say is, and we had this discussion yesterday, and I think Alan and Sarah on this call as well, which is we've had NNAG in the week just gone by. That's where we have a look at all of the activities that are taking place to resolve all the issues that were raised about maternity and neonatal. That work is continuing and continuing well. There are some issues with other groups of staff, and we are working through that. So we are not waiting for that letter to come through. We are working very hard. They are working very hard. The team there are working very hard on putting on addressing all of those issues. I'm not going to pretend there isn't quite a lot to do, not least of all to try and stabilise and make sustainable as best we can that financial position, because that will underwrite what we will need to do around the run rate around the new hospital as well. So a lot of work to do, but and no doubt about the commitment.
Thank you. Okay, going to move this on to Tim and Bob.
Thanks, Matthew. You have the now slightly out of date Chief Executive's report. However, I substituted the first paragraph with an extended rant at the beginning of the evening. That will suffice. There are a few other things just to note. So, total contrast to what I said earlier, we're delighted to have appointed architects to build the Fleming Centre, which is going to be a fantastic research institute into antimicrobial resistance, which is a partnership between Imperial College London and the Trust. And the winning entry by Stanton Williams is a fantastic building. Darzi has done an amazing job of raising money for this, and he continues to do that, raising capital. He's currently raised in excess of £100 million for the programme research that will sit behind it, and we're working on the capital. Once we have all the capital raised, we will then crack on. The aim is to get that opened by the end of 2028, which will be the centenary of Alexander Fleming discovering penicillin at St. Mary's. So it's not all entirely doomed. Just to commend to colleagues the link there about our response to the 10-year plan. I do think the role of acute trusts in the 10-year plan is a very important one, particularly how we can really contribute to integrated neighbourhood teams and population health. So I take this both ways. I think it's a good read, but if you don't think it's a good read, it's probably ideal if you don't sleep well. In terms of operationally, I would highlight that despite having the busiest major trauma centre with one of the smallest A&Es, we continue to offload our ambulances in a very timely fashion, which I think is a testament to all of our staff at the front door and indeed throughout our hospitals, who I would join my colleagues in thanking very much for all the incredible work they have been doing over the winter. A couple of specific things I just want to highlight. You'll note in 2.2, we're very unusual in trusts in London in having quite significant pressures on the maternity services, which we think is probably related to the CQC ratings, because we get a lot of people from outside of North West London. We have reduced the referrals we're taking late from outside London because there is extensive choice, but we are also proposing some other demand management within North West London. So because we're all on Cerner now, we can actually see whether people are booked into multiple trusts. That's one thing. But actually, we are not seeing any concerns in terms of key safety metrics or anything like that, but I am concerned about patient experience. And certainly when Janice and I walked around Queen Charlotte's just before Christmas, they just had an enormous amount of work to do, absolutely enormous. And I think there is a health equity thing for us here, which is that we've got people coming in from outside of North West London, and we are not able to accept all of the referrals beds for the neonatal unit at Queen Charlotte because we don't have enough beds at Queen Charlotte. So I think we are going to have to do some more formal demand management for patients from outside of the sector. So just to flag that this is definitely, I think, phase one in an ongoing process. Most of the other stuff you have seen, some important leadership changes. Dominic Allwood, who's one of our consultants in public health medicine, has now been appointed as the Chief Exec of Imperial College Health Partners. That's the Health Innovation Network. I happened to walk into Charing Cross and met our app development team, the car park, who were very keen to talk. And then one of them said, are you going? And is Dominic taking over from you? So I just want to be absolutely clear. Appointed as the Chief Executive of Imperial College Health Partners. Barry Paraskiva has been appointed to the Hospital Medical Director of St Mary's, which is a really good appointment of one of our general surgeons. But big thanks to Debbie Gould, who's did a fantastic job actually as the hospital director. And very good to see Susan Barry appointed now as the Director of Midwifery. I think it's great to have that post filled. And to note, Alison Holmes, who used to be our Director of Infection Prevention and Control, has come back from exile in the University of Liverpool as the Director of the new Fleming Centre. And then finally, because obviously it's one of my first loves, just sort of the research thing, 36,184 participants into NIHR portfolio studies. 225 new studies at ICHT this year and some good commercial trial activity. Very pleased that London North West have got one of the NIHR commercial study research centres at 14 in the UK. So hopefully that will really add to North West London's ability to deliver commercial trials, which is very good. And then finally, loads of people have won competitive NIHR research awards, which I think is fantastic. And if you look at 6.6, you will see they come from a very wide range of professions, which I think is probably the single most important thing. They're all doctors, which is a good thing. And finally, Jill Chumley, our consultant nurse in pain, and Shian Hetiarachi, named by everyone as H, who's one of our plastic and reconstructive surgeons and our former director, have both been awarded OBEs in the New Year's Honours. We've achieved HIMSS level 6 for St Mary's, 6 out of 7, which is excellent. And there's a range of other accolades for a very large number of people, and 18 of our clinicians have been awarded academic promotion by Imperial College London, including, I'm pleased to say, Anakwe, who is sitting at the end of the table.
Thank you. Bob.
Thank you, Matthew. Firstly, can I take the opportunity to sort of reinforce Tim's comments about the pressure on maternity? Because I went and walked around there with Janice myself very recently, and it wasn't just the growth pressure that struck. It was the complexity pressure from outside of area and the implications that has on a very pressurized unit. They were coping brilliantly, I have to say, but it's evident that it was there. As far as standing committee output is concerned, hope it's clear and explanatory. Picking up a couple of comments that colleagues have made, to Helen's point, we had a very good conversation about BAF and risk appetite, and recognised how high up the agenda state issues were in that. Guess what? They're going to be re-looked at. So we will go around the house again on that, and we'll bring that back. But I want to talk with exec colleagues and Nick as audit chair as part of that piece before we then bring it back into standing committee for next steps in place to a point we raised earlier. And to David's point about just occasionally talking about nice things rather than grim things, I'll reference the astonishing response on the staff survey. So we really look forward to seeing the detail that comes out of that, but well played everybody on that. And secondly, we also asked for, can we hear more formally about patient compliments about services they've received in addition to the complaints piece that we hear? And those struck me as being two important things that we should talk about in the context of thanking people and recognising the challenges that they're
Great. Thank you, Bob. Last back to Leslie and Patricia for Chelsea West.
you. Well, I won't say any more about the pressure and safety. I think it's interesting actually that research has played has been mentioned by all of us, and I think it is important that we remember there's a lot of amazing work that goes on from our clinicians who are also undertaking academic work, and you will see a couple that, as well as the research, you will see the work that we've done around some of the cultural inclusivity work, which is really interesting. Well, and again, that is playing a part in research that goes across all of the organisations, and you'll see a really interesting piece of work around so the generation study, which it will not just be at Chel West, but will precisely because it is looking at babies, the genome sequencing for so really interesting stuff. I mean, the other interesting bit is the stuff around AI and how we're starting to use AI in terms of the monitoring and diagnosis of the patients. And I'm sure that's something for people as they sit around this table over the next number of years. And we'll see a lot of work around celebrating success. And again, interesting work around maternity and the cultural inclusivity, and a really nice piece of work around the healthcare support, which is particularly as we start thinking about development of and the different ways of developing staff as they come into our organisations across the patch, is something that I think we should note and be very pleased of. For those of you who have been at Chel West, you'll have gone up to see Neptune Ward, and again, this was a piece of work, but this is a piece of work for our children with psychological and mental health illness. That is a joint piece of work between the acute units with the charity and with our mental health colleagues that seeks to both look after them in an outpatient basis, but now in Neptune to provide an inpatient place where they can be looked after in much better surroundings than we've managed before. So really nice. If you haven't seen it, again, have a look at it. Lots of other things actually, but I think I'll stop there.
Very good, thank you. And Tricia.
Lovely, thanks. I mean, sort of, we had a standing committee last week. I think performance overall is really good. A couple of challenging areas around flow and A&E. The finances are good, and one of the things, just to add to what everybody else has said, is it'd be very easy to think that these things happen by chance, but there's been a significant amount of work is put in day out by all of the executive team and the staff at Chelsea and Westminster. So whilst it looks a very comfortable position that this trust is in, it's not because people aren't working incredibly hard, and next year will be as hard again for people, I've got no doubt, but it's sort of commendment for the hard work. And also Leslie's now joined with Hillingdon as the CEO, and from my perspective, and hopefully the rest of the board feel this way, so far so good, because we haven't noticed any difference in the service that we're receiving. So that, I mean, I think that's really positive, and well done, Leslie, for being able to sort of double your workload but make us feel as if there's been no change.
Thank you, Tricia. Yes, we'll look at in that only the positive way intended it, and not any of the other ways it could be interpreted. Thank you. Very good. Thank you very much. So I'm on to any other business. Haven't had any advice in advance. Any got? Right. In which case I will close the formal part of the meeting and open up to questions from the public. I've not received any in writing this time. So if people want to raise their hands, we will take questions. Robin.
Yeah.
Robin.
That's gone. Thank you, Chair. In the meeting, we've heard many examples of clinical progress, better ways of working against enormous challenges. And yet, when we listen to the leader of the NHS, Secretary of State, he's always saying that there's resistance to change, and before resources can be allocated, there's got to be change. Could you give us an illustration of a change you're resisting that would make a difference?
Well, tremendous question, and I can see the chief executives pushing their chairs back from the table rather than.
No. I mean, in all seriousness, Robin, I mean, you know, I think we have to accept there's a public narrative at the moment that is designed to result in a set of behaviour changes across the entirety of the NHS. I think, you know, to be honest, I think North West London has always been a pretty innovative part of the NHS, and I think that that we will continue to do that. I do think, I mean, one of the things I would say is that, and one of the things that we're looking at internally is I think that the way that clinicians practice, interestingly, this is a personal view, so, and it could be absolute nonsense, but the way clinicians practice basically doesn't change from the moment they're trained to the moment they retire. When I go to outpatients, I basically do the same thing in the same way that I was taught on the first day of medical school. And it's quite interesting because they're doing that against a backdrop of everything else changing around them. And I don't think we're very good at really helping all of our staff. We have some fantastically innovative people, but we do need to work out how to equip our staff to deal with what will be a rapidly changing environment over the course of the next 5 years. If you think about how AI, how the ability to use unstructured data and all of that sort of stuff is going to change the way we do work in the next 5 years, I think we need to make sure that our training of our clinical staff allows them to take advantage of that and not feel threatened by it. But generally speaking, I think our organisations are genuinely at the front of the queue in terms of wanting to change to make things better.
Thanks, Tim. Arnell, I'll come to you. Thank you.
Well, good afternoon and a happy new year to you all. My name, for those who don't know me, my name is Armel Thomas. I have lived in Harmondsworth in the south of Hillingdon for 56 years, and I'm the founder member of Hillingdon Hospital Trust in 2006. So first thing is, I'm absolutely delighted that Leslie is now our chief executive, and I look forward to getting an outstanding CQC. If you've done it at Shells West, you can do it at Hillingdon. I'm sure we've got the staff. I also want to thank Jason. I know he's worked extremely hard to actually get us over the line under Leslie's stewardship. I am a little bit concerned about the money, and I think that that really is about St. Mary's now, and that's a group of hospitals. There are a lot of millionaires and billionaires who could actually help you. And I'm not sure you've got philanthropy. You've got I'm sure a lot of Elon Musk in the UK and abroad. You've got Lord Sainsbury's, Lord Brown, and probably of BP and loads of them. I cannot understand why you cannot actually talk to them and try to get possibly a unit. If you can't rebuild in a one go, possibly because you haven't got the space, we do in Hillingdon, but maybe not in St. Mary's. But I think you could possibly actually get them to help you financially, and they could put their names on the unit, for instance. So that is one way to go. I also haven't heard anybody mention, not only today, but before, all of you have got individual hospital charities, and a scanner was mentioned earlier on. Well, I'm sure that a scanner could actually be bought out of the charity money in whatever hospital it happened to be. And the last things I wanted to mention is maternity. We have just been told that there are not enough babies and that us oldies are costing you know, the country a lot of money, and they are not going to be able to support us. And yet we hear that maternities at you know, work at full pelt. So which is it?
Right, starting with the last question first, it might be the easiest. So the maternity problem we have at Queen Charlotte's and Mary's actually is unique in London. So across London as a whole, the birth rate has dropped and maternity units are less busy. And it was speculation as to why that is, but my suspicion is it is related probably to the CQC ratings at those 2 units. So that's what we're having to manage in that regard. In terms of the central London hospital, so you are right. Within a reasonable distance of St Mary's, there are quite a lot of rather high net worth individuals, I think is the phrase. There are also, however, very large numbers of people who live in very deprived areas. And if you think about just probably 500 yards from St Mary's, if you go up to the Edgware Road and turn left and you get to Church Street, that is the poorest part of the city of Westminster. And the difference in life expectancy between there and Hyde Park is 13 years. 20-minute walk, 13-year life expectancy. So there are an awful lot of patients that we serve in that part of London who are not high net worth. Having said that, your point is absolutely correct in the sense of we have to think of every possible mechanism for trying to make rebuilding our hospitals a reality. And I think that will really include throwing the net wide. Final thing on the charities, it's very difficult for the charities to support things that are basically the core business of the NHS. So in other words, the NHS has to do the stuff that is core business, and charities can then make the experience better for patients, make the experience better for staff, and add additional sort of value that way. So buying a scanner that you would need to do your basic job shouldn't be or can't actually be funded by the charities.
Thank you, Tim. And Meryl.
Hi there. A bit like Tim, I feel very depressed after hearing the new hospital's decisions that came from the Secretary of State yesterday. Had a bad night last night. But Tim's statement today, I think, was a very helpful one. It was detailed and it was informative. And as Secretary of Hammersmith and Fulham Save Our NHS, it was very helpful. So I want to ask Tim whether he will publish the full statement as a complement to the brief statement that he's made on the Imperial website. And if so, could he do so soon, as I've tried to write a newsletter this morning to cover this issue?
Yes and yes. Obviously, I made a statement in a public board meeting, so I was not doing that, not expecting it to be in the public domain. So we will certainly publish that probably on the website ASAP.
If that could be done very soon, that would be very, very helpful.
If you were to contact our Director of Experience and Engagement, Meryl, I'm sure that you could get a copy very, very speedily.
And Mike.
Oh, apologies that I wasn't able to see all this meeting, but I quickly wanted to ask Pippa, from a quick discussion we had at your last meeting, whether she'd been able to advance the radiological department she was trying to establish at Northwick Park, and also if Ealing Hospital is also part of the, or rather Meadow House is part of Ealing Hospital. I do believe there was some refurbishing due to Meadow House, and if so, has it advanced? Or how has it advanced?
So Meadow House, yes. So Meadow House, we've just published a new strategy. So Meadow House delivers complex palliative care, and it's one of the unique NHS-funded hospices, which we're very proud of. We have just published a new strategy and a new model of care, and we are just starting some renovation work in there. So that work is progressing now, and we've had great support from communities from charities to be able to do that work as well on top of NHS funding, which has been really helpful. The radiography department, I think you're referring to the CDC, Mike, the community diagnostic.
I think so.
Yeah.
We had a,
diagnostic centre.
Sorry, we had a quick chat with it, and you said the only units you had so far were out at Mount Vernon, which was miles away from anywhere.
No, so the community diagnostic centre, so the main hub is open, it's at Ealing, and that delivers a new diagnostic capacity for the whole of North West London. It's got all radiology modalities, as well as other tests like ECGs and cardiology tests. So that is fully functional, and it's delivering to its plan currently that was set. There is also, it's a hub and spoke model, so there is also 2 other CDCs, one in Willesden, one in Wembley. So the whole of North West London has an additional diagnostic capacity across all of that. They're all open and they're all fully functional.
Great. Thank you very much.
Would it be possible to make one more? Well, it's really an observation. My partner was in hospital over the Christmas period, and while she was there, she had to have what's called a lumbar puncture procedure. I don't know how many of you are actually know about a lumbar puncture procedure, but it involves the patient being conscious, not moving 1 millimeter, and it hurts. And the 2 things I would say about that is that you need obviously a doctor to do the lumbar puncture procedure, and it's a good idea if they have their phone turned off at the same time, and they need somebody to collect the samples of spinal fluid. But you do need absolutely at least a 3rd person. That 3rd person has to really hold the hands of the patient, that is, and sort of give confidence to the patient to make sure they don't move 1 millimeter, even though it hurts like hell. May I just sort of mention that, because it seems to be the fact that you do need this person that doesn't even need to be medically trained, but does know really to give the patient confidence, if you see what I mean, when they're having a particularly painful procedure in which they can't move 1 millimeter.
Yeah, that's really helpful, Mike. And I accept that. We quite often use our healthcare assistants for that.
Thank you. Okay, well, that's the end of the questions. Thank you all for joining us. Thank you to the members of the public who joined our board meeting. Pleasure to see you all. Thank you for the members of the board. We're going to take a 10-minute break now, and we'll be back again. So enjoy the rest of your afternoon. Thank you.
Right.